Good morning, sir.
Good morning. Hello.
Yes, sir. Good morning, sir.
Good morning. How are you?
All well, sir.
Hope all are fine after the yesterday's party.
Yes, sir. Sure, sir.
Had a good sleep, I suppose.
Yes, sir. We had a nice sleep, sir.
So we are here to continue on what we did yesterday to the surgical session with little more advanced cases. The first case what we are taking is a revision frontal sinus surgery requiring some, extended approach. So regarding frontal sinus, I want to just share certain things with you. Yeah, you kar do. Before we move on to the surgical part. Are you getting the PPT?
Yes, sir.
So once it comes to frontal sinus surgery, you have to be, first of all, well versed with the anatomy, cellularity, and the structures in the vicinity of the frontal drainage pathway, which can complicate the frontal sinus surgery. Frontal sinus surgery is challenging, always considered challenging due to certain reasons. And number one is its strategic location, lying superiorly and requiring angle telescopes to visualize inside. So you have to be well oriented with the angle telescope to do a desirable job. Number two, it's a bone, this sinus is surrounded by important or critical structures, particularly at the level of the drainage by the orbit and the skull base on either side, which are in very close submillimetric distance, and even a slightest disorientation can lead to complications, major complications. Third is you know, the cellularity at the frontal recess is so variable. So variable. Anatomy of the frontal recess is so variable. So you have to be taken to account all these factors, and it requires a good three-dimensional dynamic radiology to get used to it, to identify it, to get used to identifying it for particular patient. And here I am sharing you some of the facts, like to begin with the most basic, the uncinate process. One must follow the uncinate process dynamically on CT scan where exactly it is inserting. See all the three, that's the most common phenomena where the uncinate goes upward, joins the medial wall of the agarnage and insert on the lateral wall, that is lamina papyracea, giving a medial drainage pathway. And this is the safest and the commonest, phenomena. In more than 98% cases, you'll find the uncinate going like this. You may still find variation by variation in the agarnage as it joins the medial wall of the agarnage to insert on the lamina. So sometimes agarnage is too big, can push the uncinate. Sometimes it is, very small agarnage and you may not find the upper uncinate insertion fusing with the agarnage. So sometimes it is too big and can push this turbinate to insert on the skull base. This is such a dangerous phenomena. As while doing uncinectomy, you can initially, in the initial phase of surgery, where the first step is uncinectomy, you can give a CSF leak. Similarly, it may insert onto the turbinate as well, and manipulation of the turbinate or manipulation of the uncinate can lead to turbinate manipulation, which inserts on the cribriform plate and give problems. So the basic thing, once you think about sinus surgery, plan surgery, you must be thorough in three-dimensional CT scan to know where exactly your uncinate is going. That is very, very important. And, all these three insertions can give variety of problems. And the most important thing in the radiology, when it comes to radiology regarding frontal sinus, the most important reconstruction is the sagittal section reconstruction. Right? Sagittal sections are most important in knowing the anteroposterior anatomy and the relationship with the skull base and the beak. This is one of the most important sections by means of which you get point details of the frontal sinus. Like in this is the beak. That is the biggest obstacle. The cell which is inserted on the beak. Beak is forming the anterior wall of the frontal sinus as well as floor, and behind the is the skull base. So this is the agar negi, which is inserted, almost always present on the anterior wall, inferiorly on the beak itself, and posteriorly are the bulla, suprabular cell, and other variations which are inserted on the posterior wall. And this is best depicted on sagittal section. So by and large, these are the cells in the frontal drainage pathway attached to the anterior wall, like Kuhn described, type 1, 2, 3, 4, and the Aganegi cells. And posteriorly, the suprabular we have seen yesterday, frontal bular, supraorbital cell also we saw yesterday. All these cells are attached to the posterior wall. Intersinus septal cell is a different cell which, you know, makes your frontal recess work more difficult by means of displacing the frontal drainage pathway laterally. And I am going to keep one of the case to show the intersinus septal cell causing difficulty as well after the draft cases. So Aganegi are the simplest, as we discussed. The lower cells, the moment you put your endoscope, anything attached to the beak in the frontal recess anteriorly are the Aganegi, and you can see this prominence above the level of the axilla. That is Aganegi. Those are simplest cells. You can see in these diagrams all Aganegi. Adding on to the difficulty, what Kuhn has described are type 1, 2, 3, 4 cells. So Kuhn type 1 is a cell above the Aganegi, yet below the level of the beak. Adding on to the difficulty, now you have to go, see, for all these cells attached here, you have to go behind them and fracture them anteriorly, like you have seen yesterday. Go behind the uncinate and fracture it anteriorly. Go behind these cells. That's a safe maneuver, and fracture them anteriorly. Type 2 cones are tear of cells. See the tear of cells attached to the anterior wall. Number of cells 2, 3, 4, but still below the level of the beak. More difficult than the type 1. So you have to individually, take care of all these cells and flush them all with the beak so that your frontal drainage pathway is widened. This is type 2. Type 3 is the cell when one of the cell go above the level of the beak. See this? And that makes the life difficult for the surgeon. Now in order to remove that cell, you have to go all the way above this cell and then fracture it anteriorly. And this beak is the biggest obstacle. See, you are coming from here, type 3 cell like this, and this thick beak is there. It will not allow you to visualize this, and this will require some sort of drilling of this beak so that you can get onto the cell and the posterior superior wall of the cell, so you can remove it under vision. So this is adding on the difficulty, and this is type 4 cell, where the cell is much above the level of the beak. See the beak, see the height of the frontal sinus, more than 50% of the height, or approaching 50% of the height. The idea is to adding on more and more difficult. This cell cannot be removed without removing this beak. As simple as that. And this will require draft procedure. Can be isolated cell well above. So all these cells can be removed only after removal of the beak. These are the cells which are attached to the posterior wall. See this? Attached to the posterior wall, you cannot afford to go behind and remove them. See, this is suprabular cell. If it goes further in the frontal sinus, frontobular cell you had seen yesterday. And what you need to do is, you have to remove this anterior wall to flush with the posterior wall, like we simply did yesterday. So these are attached to the posterior wall. Now cell attached to the anterior wall, posterior wall have different attachment, different way of removal. You have to be very clearly knowing what cell is attached where. Another is the supraorbital we discussed yesterday. See the supraorbital cell going up beyond the orbit, behind the level of the frontal sinus. This is frontal sinus is anterior. This is behind the level of the frontal sinus, going above the orbit. Yesterday we did one of the case having supraorbital cell, and this cell has to be thoroughly seen on all variety of whatever CTs can see in all planes to get to the proper diagnosis. This supraorbital cell is important. Sometime one may assume this as a frontal sinus itself. Supraorbital cell is a relationship with the anterior caudal artery, which is immediately caudal to it. So it's a very important structure. One must be able to identify it. Then intersinus septal cell. I am going to keep one of the case for the intersinus septal cell as well, where This pneumatizes the intersinus septum and pushes the drainage pathway laterally. This opens into either of the frontal sinus. On dynamic CT scan, we should be able to see which frontal sinus it is draining in, so that we can widen the access of the drainage into the frontal sinus. That is the treatment for this cell. I'll show that. Now, this cannot be, the cells attached to the anterior wall, posterior wall cannot be defined very clearly on coronal CT scan, though I told yesterday, see, this is so anterior a picture, you can't see the frontal sinus. What this cell looks, it looks like attached to the anterior wall, could be type 3. This is the level of the maxillary sinus you can see now, and see, it is far behind the frontal recess. See, this was the beak, here there is no beak, this is the level of the frontal recess, and this cell going up looks like frontobular. How can you differentiate? Just put the sagittal section. See, this cell is attached anteriorly and this behind. You can easily differentiate by means of a sagittal section what kind of a cell is what. Like, I'll give you certain examples here. वो देना, वो थी ना इसके साथ हार्ड डिस्क होगी यार. I'll give you certain examples. Just a moment. We need to discuss frontal sinus thoroughly, and this is something makes the life of the surgeon difficult. See this, some examples of the supraorbital. I'm just showing you some of the examples, so it gives you a clear-cut picture of what exactly these, variety of cells are. So, for some of our patients' example. See this particular scan. See the sinuses, frontal sinus. It looks like 3 frontal sinuses. This is not 3 frontal sinus. See, I am going behind. Now see the value of dynamic radiology. Beak is there. See, if I tell you amongst all these cells, intersinus septal cells are the most anterior cells. Most anterior cells. This is, see where my cursor is, what is this? See this. This is intersinus septal cell, which is communicating with the frontal sinus in the frontal recess level, so behind. See, this is such a big intersinus septal cell, and it has pushed the frontal drainage pathway far laterally, and this cell itself, aeration of this cell is blocked, and you can see the opacity there. Sometimes they make your life so difficult to distinguish. It is your dynamic radiology which can tell you which is intersinus septal cell, which is frontal sinus, and you should be very clear about it. Similarly, this is supraorbital cell. See now, this is your frontal sinus. See the level of the beak. Now, as the beak is going, now the frontal recess starts. See, until here was the beak. That's the most anterior picture. Now the beak has gone, and see things looking like frontal sinus. Same picture of frontal sinus. This is not frontal sinus. This is frontal recess. And what you see, this pneumatization above the orbit is supraorbital cell. See this cell. If I show you in all planes how the supraorbital cell looks like, see how the supraorbital cell. The frontal is far anteriorly and the supraorbital cell is behind. This is supraorbital cell, frontal sinus is far anteriorly. So this is how you can pick up the supraorbital cell very easily. There should be no confusion in identifying the supraorbital cell. Another example. Another example of supraorbital cell. See this, frontal sinus draining. Now the frontal recess started, and see the big pneumatization above the orbit. That is, now see the cribriform plate in view, the frontal sinus we have left far anteriorly. That is not the level of the frontal sinus. And if you see in all planes, see this, See this is supraorbital limitization. The frontal sinus is left far anteriorly. So that is something. See, the frontal is left behind. This is orbit. This is supraorbital cell. Wide pneumatization of the supraorbital cell. See this? The entire supraorbital cell, you can visualize, this is above the level of the orbit, pneumatizing the orbital plate of the frontal bone. So we should be able to identify these cells very, very clearly. Another example. See this particular patient, if I reconstruct, see this. See the huge, I remember this patient had a huge intersinus septal cell. And see where it is communicating. See, it looks like 3 frontal sinuses. Where the actual frontal sinus is, see is the beak. See the beak. Now the beak is going, this is frontal sinus on left side, and this is intersinus septal cell, which is opening into the frontal sinus behind. This is opening in the frontal sinus, and that is the frontal drainage pathway. So now what you need to do is, you have to widen this, remove this party wall and widen the drainage of the intersinus septal cell in the right frontal sinus. That is the treatment. See the value of dynamic radiology, you can actually get to know how this cell is communicating to the frontal sinus. If this frontal sinus drainage pathway is widened and this cell is communicated, that's the final answer to this problem. So we should be able to know which one is the frontal sinus and which is the intersinus septal cell. Again, this example in the series of examples, this is one of the classic examples of, frontobular cells, I can say. See this particular patient. Let me show you the coronal and you can pick up what kind of cell it is. That's an important finding. See, I will run the CT scan and show you. See the frontal sinuses? Frontal sinuses, absolutely no cell so far. This is the clue. See, right from anterior here, no cell so far. Now see carefully. Can you see some cell appearing in the left side? Hello?
Yes, sir.
See this cell appearing in the left side in the frontal recess region. Looks like isolated cell. See this cell. What it could be? See this, where it is attached to. How to see? How to confirm? See this cell, and I take my cursor into it, and you see there. This cell is actually a frontobular cell attached behind. That is the drainage pathway anteriorly. There is no anterior attachment. This is classical example of a frontobular cell obliterating the frontal sinus drainage pathway from behind, like we saw yesterday, and you have to flush it to widen the frontal drainage pathway. So there are many ways you can identify all these cells, and that's how these cells can be easily addressed, not complicating your surgical course. Now see carefully what kind of cell it is. First, let me show you coronal. Right. See what kind of a cell it is. Again, I am showing the example. Anteriorly, no cell. This is intersinus septal cell, most anterior one. See, pneumatizing the septum. Can you see clearly? And this is opening to the right side. Clear?
Yes, sir. Yes, sir.
Now see some cells appearing on the left side. When? Posteriorly, when the drainage pathway starts. Posteriorly cell coming means these are attached to the posterior wall, not anterior one. And that is so important. The beauty of this dynamic radiology, you can change your window settings as well. Now see, if I focus on these posterior cell, you will find See this? These cells are attached posteriorly. These cells are attached posteriorly. See, this is projecting into the frontal sinus and making the life of the surgeon difficult. And sometimes, because of these cells, once you see something big in the frontal sinus region, one can easily assume this could be the frontal sinus. So, frontal sinus, surgery is challenging because of these regions, and one must be very, very careful in identifying, all these things to execute a proper surgical plan. Now, what can be the reasons in the persistent frontal sinus surgery? Persistent frontal sinus disease. This case, the next case is a revision frontal sinus surgery where the surgeon has done earlier reasonably good frontal sinus work, but given scarring, left some cells and ultimately led to the frontal sinusitis, which has become symptomatic. So there are so many reasons why frontal sinus is considered challenging, and these are the reasons for the persistent disease in the frontal sinus. There could be because of the inadequate, information on the radiology, or not proper reading the radiology dynamically, three-dimensionally, one can miss the cell. Sometimes you get a imaging only a single printout. Majority of the time patient once it comes from somewhere, gets a single printout, which is of practically no use. No use at all. You have to get the radiology again properly 3D dynamic so that you don't miss anything. Missed cells are the most common cause. You have done a good frontal sinus work, left lot of cell partitions leading to fibrosis and blockage. That's what you will see in this particular case. Lateralized middle turbinate, if it is floppy, we saw yesterday, and we had to, address the turbinate in both the cases because they were pneumatized, floppy, and they could lateralize and block the access to the frontal recess or the ethmoidal access completely. And we should not be overzealous in removal of the lateral wall mucosa from the turbinate, otherwise may lead to synechia in the narrow recess. Circumferential stenosis of the frontal sinus, excessive denusion of the mucosa. This is one of the major regions. So while working in the frontal sinus, I was showing you again and again yesterday while showing the beak and everything, the mucosa is intact. Because you have to leave intact. If you leave a lot of raw areas, can lead to fibrosis, crusting, and there's a good, background for the synechia to form, and can expose the bone, which may get infected because of the ongoing inflammation and can lead to osteitis. One of the major reasons for the osteitis, we discussed yesterday osteitis, one of the major reasons besides the ongoing inflammation is the revision surgery, exposing the bone, leading to inflammation of the bone, and that is one of the major reason is persistent osteitis. So these are the major causes, need to be individually, thoroughly assessed in every case when you are dealing with the frontal sinus. So what can you do in those situations, difficult situations? The challenge in the frontal sinus is once you work over there, this beak, you need an angled scope, angled instrument, and the biggest obstacle to go inside is this beak. And to overcome this, there are various procedures described, and I am going to show you all draft. Type 1 I had shown yesterday. Type 2 and 3 I am going to show today. Type 1 is simple. You remove all the cells below the beak and making in continuity with the frontal sinus. See, this is type 1. No cells are left below the level of the frontal sinus. You are not supposed to remove the beak, but all cells removed. Draft 2 is removal of the ipsilateral floor of the frontal sinus, making it draining right into the nasal cavity, sort of marsupialization, ipsilateral. People have divided for their convenience into A and B, where the A is the medial limit, turbinate, and for the B, medial limit is nasal septum or intersinus septum. That is, we'll discuss during surgery in detail that. Under type 3, or the draft type 3 is modified Lothrop, where you do both sides draft 2 along with removal of the upper part of the septum and intersinus septum and drain both the frontal sinuses entirely endoscopically into the nasal cavity. It's a sort of complete marsupialization of the frontal sinus. So this is, a modified procedure which Lothrop's described 100 years back, more than 100 years back, by external approach, removing the floor of the both frontal sinuses with removal of the intersinus septum, upper part of the septum, all frontal sinuses directly draining into the nasal cavity. That was the Lothrop described, and this is modified now endoscopically by draft and termed as draft 3. So this is all the terminology for this. So draft 3 will show today. You remove, the complete floor of the frontal sinus, removal of the intersinus septum and an upper part of the septum, the entire septum, this is draining into the, nasal cavity. Now, due to certain regions, indications, these Lothrop procedures are further modified. Modified means when you don't have such extensive disease directing the need of complete draft 3 or modified Lothrop, with some limited disease on one side, you can modify your procedure accordingly. And we do it in a lot of cases according to the need. For example, quickly, what is modified subtotal Lothrop? Draft 2 on one side. If you have a far lateral disease, supraorbital cell which is not being accessible from the same side, you can do a septotomy and come from the opposite side to reach the far lateral area. Addition of the septotomy. And if you have a disease in the opposite frontal sinus also, which you don't want to, violate the opposite frontal recess, you remove the intersinus septum as well. So draft 2B with septotomy with removal of the intersinus septum, and you actually don't violate the opposite frontal recess. This is modified subtotal Lothrop. So what you are doing is, if the opposite frontal recess is good, you can drain it from the opposite side, removing the disease on the opposite side where the disease size is done, and you can access far laterally through the septotomy. This is modified subtotal Lothrop. Hemilothrop is you have a unilateral disease, don't need to remove the intersinus septum, but going far laterally, you need a septotomy. So draft 2 with septotomy and coming from the opposite nostril going far laterally is hemilothrop. Mini Lothrops is important condition. One everybody should know. This is a rescue procedure to prevent you, from difficulty. If somebody has done the frontal recess work earlier, which has led to some complication, also some orbital fat prolapse, lot of scarring, fibrosis, and we are not able to, not wanting to go into the same field for the persistent frontal disease. What you can do is avoid that. Go to the normal virgin side, do a draft 2B, opposite side, normal side draft 2B, and remove the intersinus septum and drain the diseased sinus to the opposite side. Rather than going into that, already difficult frontal recess because of the previous surgery. So that is modified mini Lothrops. You have to understand each and every modification, and accordingly you can use them for the particular indication. Central Lothrops is for like certain, intersinus septal cells when you have a bigger problem in the central and both central part and both frontal recesses are good. Why to unnecessarily violate the normal frontal recesses? You can work in the central by removing only the floor in the central and draining that intersinus septal cell and communicating with the both frontal sinuses from midline without violating the frontal recesses on either side. So these are the modifications one must be aware of. Another process, which was very common earlier, these days more and more uncommon because of the advancement in endoscopic surgical techniques, is trephination. Trephination is making external opening into the frontal sinus, and you can use it for many reasons. Sometimes you have a difficulty in identifying frontal recess. You can make an opening from above and put some dye from there to locate the frontal sinus. In excessively lateralized mucoceles to get more access. Isolated type 4 cell, you are not able to, do the draft from below and not able to excise that you can come from above. So with any draft 2 or 3, you want one more hand, one more port for tumor removal or anything, or CSF ligand. So it gives an additional port to the endoscopic surgery and can be used for some time for post-operative irrigation as well. So trephination is done in the medial part of the frontal sinus, roughly 1 to 1.5 centimeter from the midline of the glabella to enter into the frontal sinus. This all depends upon the anatomy of the frontal sinus. Get a X-ray Caldwell view of the frontal sinus and you can mark that area where the frontal sinus is, so you can exactly do the trephination in that area. But this is one of the useful procedures. You can carry on. Maxillary sinus, I can leave here for the later. So these are the important procedures. I can say one must be well versed with, being a frontal sinus surgeon to these procedures. So our case is ready. Anything before you want? Any questions or anything? Hello?
No, sir.
Do we go ahead with the surgery?
Yes, sir.
Okay. All right. Okay. Lastly, I want to show you the CT scan of this patient which we are going to operate. See this. Why we are planning a extended frontal sinus procedure for this patient. See this. This is an operated patient. See, a reasonably good sinus surgery has been done. Reasonably good sinus surgery is done with some mucosal, edema in the frontal sinus with good openings. It can work with a good irrigation without doing anything. Now see what is happening anteriorly. That's the middle turbinate. See the cell left behind. The big cell, the agar cell left behind far anteriorly. See this? Far anteriorly, this cell, see this is the agar cell far anteriorly. And these are multiple cells in the anterior ethmoid which were left behind. See this persistent cells. I told you the biggest region for the revision surgery in the frontal recess is the persistent cell, then lateralization of the turbinate. These and the reason for the persistent cell is inadequate or poor radiology, you can say. So now see this cell is left behind. This is supraorbital cell, the big supraorbital cell. See this big supraorbital cell coming anteriorly. See this cell partition with the frontal sinus, not removed. This is the partition between the supraorbital and frontal. So lot many cell and the frontal sinus disease is persisting. So this is one of the most challenging situation, and this patient has a lot of scarring in the frontal recess. Now going back into the same field, see the orbital wall is intact. Absolutely intact, no complications in the orbit. So what I have planned in this particular patient, so that, and he had a mucosal disease, you can see the maxillary in all sizes, which requires eosinophilic disease, which require long-term irrigation as well. So now what you can do? Options. You can go back and revise the frontal sinus surgery like we did previously. But in the area where already so much of scarring and persistent cells may give, further problems, may require further surgery if this patency doesn't remain for long in already diseased frontal recess area. The definitive procedure is a draft 2 on this side. It is a classical example of a draft 2 procedure. If we need to go far laterally to visualize the supraorbital recess, if something warrants, I can add on a septotomy and go from the opposite side like that. See, that is adding on septotomy to come from opposite side like that. That is would be modified hemilothrop. I'll do a superior septotomy here and come from here to the opposite side. That is addition to the draft 2B, and that will be a modified hemilothrop in case required. Third thing, had there been some more problematic situation at the frontal recess area where the previous surgeon might have given an orbital prolapse or something. See, somebody which is not good at frontal sinus surgery giving problems may give complications also in the vicinity, may have got disoriented, whatever, and may have opened the orbit, flat prolapse, and given more problems. I would not go from this side and I would execute a modified mini lothrops. I would not go in this frontal recess and I would go from the opposite side, remove the intersinus septum and drain into the opposite side. But this is not indicated in this case because it is not a frontal sinus which is problematic. Problematic is a lot of cells left in the frontal recess. This frontal recess also, requires proper address. And that is why the indication for this particular patient is a draft 2 on the same side. This is a classical example, I'm going to demonstrate. The next case is one of the most difficult situation one can come across. That will be for draft 3, which I'll discuss later. So this is a proper draft 2 situation, which is required, and I'll show the, various ways of, I'll tell you the landmarks to be taken into consideration for draft 2 and the surgical technique for draft 2. This is not a difficult procedure. Rather, I tell you, draft procedures are much easier. You work in the most safe area. There's no critical structures in the draft 2 when you do. Only thing is your skull base that you have to define behind first as a first olfactory neuron. Okay? So, this will be a draft 2 procedure now. This is a special session on frontal sinus. As people, I have, personally met so many people yesterday demanding more and more frontal sinus because they always, find difficulty in frontal sinus. So I kept, initially some of the frontal sinus cases, difficult frontal sinus cases. Hello, are getting the endoscopic picture? Hello.
Yes, sir, getting the picture.
See now, that's the what the previous surgery shows, and we have seen the CT. Reasonably good work. See the little edematous mucosa requires. See even the opposite side. See this? There is scarring, though opposite frontal sinus is normal getting aerated, but still, to me, this is a lot of scarring. But since not giving problem, why don't necessarily create more problem? And now see, on this side is all problem. Rest of the sinuses are good, you can see. Such a good job done. But see on this side, persistent disease. See the level of the frontal recess. Hello?
Yes, sir.
Revision surgery is 100 times more challenging, I tell you. Revision. So now what we'll do, we'll go head on into the frontal sinus, and that is what the draft is described.
Sir, you are going to address only frontal sinus or other sinuses also?
Only frontal. Nothing is required in the other sinuses. Other sinuses, little bit mucosa edematous, but see, the openings are wide. See this? See this?
Yes, sir.
So if the post-operative your thyroid irrigations go properly, that will take care. Main issue is the scarring in this right frontal recess, giving him persistent problem. Persistent. See, untreated frontal sinus disease is most of the time asymptomatic. But such iatrogenic disease, this is so funny aspect. Such iatrogenic disease, which now has been given to this patient because of the inadequate work at the frontal recess, has become symptomatic and now getting headaches. So frontal sinus work, once you choose to do a complete work. That's why we almost always do a draft 1 kind of a situation, removing all cellularity, removing all septations. Septation becomes the source of synechia. As the synechia bridge the septations to connect the different walls. So those should be completely flushed to the limits to avoid such problems. So our area is, I'm just doing a exposure in this region.
This is normal tonsil band, sir.
There's a pro size max. Pro size max. This is to just improvise your field. Now, the area of interest is this. This is completely blocked. And getting into the same field is a very, very difficult job. So what we are going to do, draft 2. This is the axilla. We are going about the axilla. See, this all mucosa has to go. Our outer limit will be skin, anterior limit will be skin. See, all this mucosa, ultimately I am going to remove. See this from the upper part of the septum. Section भी रखना वो काला. See this, staying above the level of the axilla is something keeping you away from the cribriform. We all know. So there are certain landmarks I am going to show you. See, I have come anterior to the axilla as well. See this?
Yes, sir.
All this anterior area, which is very, very safe, is the target. See about target area. Nowhere close to any critical structure. That's the beauty of the draft. So don't terrify yourself. You can do draft yourself. Believe me, whoever are attending this course must be able to execute this process as well. Believe me, you can do it. There is no need to, considering these cases are difficult, no need to refer anybody. You yourself can do it. Any sinus surgeon can do it. And should be in the armamentarium for every sinus surgeon to do draft procedure, because you may need draft any point of time to do a good frontal sinus work. See, this is our area of interest. Now I can remove this mucosa that was coagulation. See what I have exposed anterior to the axilla.
Again,
See this? See, anterior to this. Superior is very, very safe. More anteriorly is very, very safe. There is no critical structure there. This is from the upper part of the turbinate. See this region which we have denuded.
Sir, after completion of the surgery, do you advise any mucosal flap to cover
A lot of people create mucosal flap. You know, this is not the sinonasal mucosa what we treat in sinusitis. Okay?
Okay, sir.
This creeps over very fast. Draw area ultimately will be very less as we are going to open the frontal sinus in the depth. Yes, people, you can create this mucosal flap antero-inferior from the septum, anywhere can apply to promote the healing, primary healing. You can do it, but most of the time it's no needed and it heals in no time. This area is a flat area, heals very fast. This doesn't contain the inflammatory mucosa. This mucosa is not involved in sinusitis.
Yes, sir. Scarring, will it lead to again osteitis and
Yeah, so this is the area, that's what I'm telling you. This mucosa is not involved in sinusitis.
okay, sir. This is suction cautery, sir, you are using?
Yes. On the bone, cobbletter doesn't work. And you should not even attempt to, otherwise can ruin the cobbletter vein. See this. See this step by step and assess how difficult if it is. Yes, it requires good tools, good cobbletter, high speed drill, everything. See, your most important area is the posterior limit that you have to define. And that is defined by the first olfactory neuron. See, I am going behind. Can you see?
Yes, sir.
Elevating this mucoperiosteum behind. Can you see something coming out? See,
Yes, yes, sir.
this is, what is this? This is a branch of ethmoidal nerve. See, what you see anteriorly is the branch of ethmoidal nerve, anterior ethmoidal nerve. That is not the first olfactory neuron. This is not the first olfactory neuron. Okay?
Yes, sir.
As you go behind, see, as you go behind, yes, this is the branch of the olfactory, the ethmoidal nerve. See, I am cutting off
Okay.
to show you.
You are using 0 degree, sir.
Yes, yes. All entire procedure will be done with a 0 degree only. Now see, medially, see something coming out of the cranial cavity. Can you see?
Yes, sir.
Here medially. And that is the first olfactory neuron. Medially. Medial opening is the neuron always. So don't terrify again. The anteriorly is the branch of the ethmoidal nerve, anterior ethmoidal nerve. You don't need to do anything to it. Your first olfactory neuron is a median structure coming behind the nerve. See, this was the nerve, and this, which I have cut, and see behind, that is the first olfactory neuron. See that?
Yes, sir.
So that is our posterior limit. The first thing I have defined. Anything anterior to it, you remove anything, nothing is going to challenge you. Nothing is going to complicate you. So you can remove anything anterior to it without any problem. Okay?
Okay, sir.
Now the area where we are going to play is the safest region in the paranasal sinuses. Safest. This is the safest region in the paranasal sinuses, and the orbit is going to remain below, the skull base is going to remain behind, and you are far, far anteriorly there. See now, I hope you are oriented.
Yes, sir.
I am doing with a 0 degree only. See this, we are going to go head on into the frontal sinus, head on entry into the frontal sinus. See this. See now, this is our high speed Medtronic 15 degree stylus drill. This is axilla, this is the wall lateral to it, and I am starting here inferiorly, just inferiorly. See, deepening it to know the level of the outside skin. See, you will find the color change.
Yes, sir.
As you reach your lateral limit, this is, I have identified one landmark. See the level of the skin, outside skin. Can you see?
Yes, sir.
See the outside skin ballotment?
Yes, sir.
This is outside skin. Orbit is left below. This is above the level of the orbit. That is the outside skin. So this is my lateral limit. Okay. Posterior limit you have seen. So the lateral limit is the outside skin. Simple.
Sir, hello.
Below. Yeah. Yes, sir.
Sometimes complicated after surgery, frontal sinus sedations. Some patients will have supraorbital abscess and leading
Supraorbital.
to supraorbital abscess, causing some protrusion of the eyeball
Yeah,
because
you can
of.
once you can with the draft you can access any area.
Okay.
See now what I'm doing. This is my lateral limit. This is skin. And this is what I'm using is a coarse diamond bar, pretty safe. With this, I am not supposed to transgress this skin to come outside making buttonhole. That is my lateral limit. See this lateral limit? See lateral limit very clear?
Yes, sir.
Keep oriented. Your turbinate is here. Anteriorly, again, the outside limit is skin. Posteriorly, we have defined the skull base, which we are not going to go behind that. Now, anything medial to it, you can quickly remove all this bone. This is forming the anterior wall as well as the floor of the frontal sinus, the beak which I am drilling.
Yes. Sir, irrigation is attached to this or somebody is irrigating?
Yeah. Attached to this, we are doing outside irrigation also.
Where is the suction, sir?
Suction is attached to this. Not to this in the nasal cavity. Suction is in the nasal cavity separately. See this now? Can you see the outside skin?
Yes, sir.
Change in color. Anything medial to it, you can remove. I hope you are oriented.
Yes, sir.
Anything medial, this entire bone, we are supposed to remove. And we will enter into the frontal sinus head on. This bone which we are removing is making the floor and the anterior wall of the frontal sinus, which is the obstacle to enter into the frontal sinus, the beak. And I'm removing it completely. Defining my lateral limit, I can go quick. This is the beauty of this burr is, see this is 15-degree curve, so my burr doesn't come in the way. My shaft doesn't come in the way.
Sir, where is the lacrimal sac, sir?
It's below. That is all below.
Okay.
We are working above.
Okay, sir.
See behind, that is our level of the olfactory neuron here. We are working above and we'll follow this skin coming anteriorly as well. The same skin is going to come anteriorly. So that will be our anterior limit.
Sir, can you share external picture, sir?
Yeah, see this. I will show you one of the sinus case because this is open now. In the sense, you are not using angle scope, you are not using any angle instrument, all head-on approach. See this. This was the scarred frontal sinus recess. Can you see? This is past scarring. Can you see this? Hello?
Yes, sir.
See, this was the frontal recess area. That is all scarring. See, osteitis, lot of cells I am removing. See this? Persistent cell in this region. I am removing all. See, number of cells in this region which were left behind. during previous surgery? Can you make out? No. Give me. See, just to show you. See, this is the big cell. Sir pakadna. This is the big cell which was left behind. Hello.
Hello? Yes, sir.
See, I am behind this big cell. See this?
Yes, sir.
Fracture this cell. See this?
Yes, sir.
See, fracture this cell which we saw on CT scan. See this cell?
Yes, sir.
This was left
Very
behind.
nice.
I told you, persistent cells are the biggest cause. See this?
Yes, sir. This is agar.
Yes, looks like. So, radiology is so important to remove. See the persistent cells again. Could you see the frontal sinus coming in picture?
Yes, sir.
See what is being done, how this being executed. See all these cells.
So during primary surgery, if this had to be addressed, it should have been addressed with draft only.
Pardon?
During the primary surgery,
See more cells. Yeah, during primary surgery,
draft should have been done, or it would have been
in this
addressed
patient,
in other.
we cannot comment at that time in this patient it was indicated. You cannot comment. See the remaining
Oh.
cells. Can you see the cells?
Yes, sir.
See the number of cells. I told you the missed cells are the biggest reason. See now, the frontal recess being cleared. Can you see?
Yes, sir.
During previous surgery, what I believe had these cells been addressed thoroughly, he would not come back.
These are anteriorly attached cells.
Yeah, see all these cells.
Yes.
How many cells I have removed? I showed you on CT also. See the number of cells. Now the frontal recess area is looking good. See this?
Yes, sir.
Our first olfactory neuron is there. See here. Yeah.
Yes.
Can you see the neuron?
Yes,
We are
sir.
not supposed to go there and violate. So what is to be preserved has to be seen first so that you don't go there and damage anything. Now, to widen further, see the frontal recess clearance.
Yes, sir.
Now, following the same work, Pani. See this remaining bone. See, we are working head on again and again, repeating. I am repeating the same word. 0 degree, everything with 0 degree. I have not even taken once 70 degree in my hand.
Can we get both the pictures outside and side?
Yeah, I will. I forgot to put up the external camera. Next case will show. See now. See how the frontal being widened. Under vision head on. See what draft has given this big gift to the world by describing these procedures.
This is the beak or anterior wall we are drilling.
Yeah, until we get the skin anteriorly.
Okay.
Everywhere the limit is skin. Worst to worst, if you cross your limit, you can give a buttonhole, you can suture. That's it. Worst to worst. Populator देना यार, पूछना पड़ता है क्या? See the frontal sinus coming up? What did not drill? Oh, public. See what you see the front. Drill. Frontal sinus, you're working with a 0 degree. See the interior of the frontal sinus.
Yes, sir.
I will further.
Which blade are you using, sir? Debrider blade?
That was red 40.
Red 40.
Keep further widening, removing all bone. See that?
Yes, sir.
You can give the widest possible opening. See the fat? Hello?
Yes, sir.
What you can do? Coblet.
Yes, sir. Sir, this suction from where it is coming, sir? From the opposite side or same side?
Pardon?
This suction, who is holding and from where it is coming? From the opposite side or from the same?
Yeah, this is my assistant. See this. That was a little fat. Now see the frontal sinus up, and I can go further more and more anteriorly. Remove all this bone. See, your limit of removal is this outside skin. See the same outside skin we are following from here, here, or turning anteriorly. Can you see?
Yes, sir.
Remove all this bone until you reach the skin. See that? Now see the complete frontal sinus marsupialized. On this side, that particularly the lateral part. See, you can see the inside of the frontal sinus very clear.
Yes, sir.
Now, see behind the frontal sinus here. This is behind the frontal sinus where I am going is the supraorbital recess. This is supraorbital recess. Let me show you like this. See the supraorbital recess there.
Yes.
Directing laterally. See that? Supraorbital recess is here going above the orbit laterally. What is it now? See this recess going above the orbit? That is
Yes, sir.
frontal sinus completely there. Okay?
Yes, sir.
So still with a 0 degree, I will show later on all around with a 70 to just apprise you. This is supraorbital recess. See far laterally, this is supraorbital recess. This is your frontal sinus. Now, if you want to go medially, in this case, it doesn't like you need to go medially. Medially means up to the sinus septum. Up to the septum, what you can do? See this. See here. Here is your first olfactory neuron. Can you see here?
Yes, sir.
You can go above and go medially. Keeping this here posterior limit, you can go medially. If you want to extend, you can remove the intersinus. See, I am working far anteriorly. See, I am going medially now, but staying anterior to the skull base.
Yes, sir.
हाँ, नहीं आ रहा ना पानी, क्यों कर रहे हो ऐसे? अब आया? यस, वॉश. See, anteriorly your limit is skin, and you can go medially like this. Go medially. See, my first olfactory neuron is here behind. Staying anterior to it, you can go medially without any problem. If you really want to go and do some intersinus work or anything, in this case, it is not required. Just to show you, I can go medially from here to the opposite side, drilling the intersinus septum. My skull base is left behind. See, this is here. I hope you are oriented.
Yes, sir.
Hello.
Yes, sir.
So I am working in the safest zone. See my anterior limit, anterior skin. See the same skin turning anteriorly. Can you see?
Yes, sir.
So that defines my anterior limit as well. See the complete frontal sinus with a 0 degree. Right side. See this? This is what draft 2 is. Can you see very clear? Now your
Yes.
irrigation will reach inside very easily. 40. Irrigation will reach inside. This is draining directly into the front, into the nasal cavity now. See now?
Yes, sir.
It is draining directly into the nasal cavity now. करना है यार. कर दे 5,000 कर दे यार. बिल्कुल आदमी रू करना. रुक जा, रुक जा, रुक जा. Yes. See my draft 2 on this side. Final picture of draft 2. तू पकड़नी चाहिए. तू पकड़. इसको अभी नहीं गिरा, नीचे रख. ये hello.
Yes, sir.
See, this is interior of the frontal sinus with a 0 degree. Complete marsupialization of the frontal sinus. Here it is supraorbital recess. Everything open, the frontal recess is completely wide and all cells removed. This is the terminate below, and here is the first olfactory neuron which is left here, much behind. See, this is first olfactory neuron. Nothing more is required to be done in this particular case. This now has given us the biggest opening. The frontal will drain automatically into the nasal cavity now, and this gives a wide access for the topicals to introduce now. So that's the final answer to this difficult revision sinus surgery problem. That's the final answer. Any questions?
Like we need not cover the raw area, sir.
It will heal in no time with irrigation. This is not inflamed mucosa. Don't worry about that. See this? The area is far anterior from the sinonasal area. See this? Yeah. See the area what we have drilled. Remember the area we marked earlier. So this surgery is in the very, very safe zone anteriorly. Skin lateral, this is the lateral skin, that's the anterior skin. And if you want to remove further, you can remove all this bone, go to the opposite side easily, or staying anterior to this first olfactory neuron. This is the region of the first olfactory neuron for everybody. This is, you can remove all this bone anterior to it. All this bone can be removed. So that will show in the next case. So this is all about this particular case. So you can accomplish this in a regular setting. This graph too, change karna, in 15 minutes or so on the one side, easily with good high speed drill or so. Connect karo. ये क्या?
Sir.
Revision है? Yes.
Hello. Sir, in routine frontal surgery,
Yes.
axillary flap technique, like your opinion?
Is not needed. Again, if you see, get used to 70-degree, all these things will never be required. These are all indirect ways, unnecessarily creating more raw areas, unnecessarily complicating the thing, what I believe. Believe me, it is not needed. और लिए कि नहीं उधर? So once you do a proper endoscopic work, you don't need anything else.
Hello, sir.
Yes, please.
Regarding irrigation, what is the concentration steroid irrigation you are?
We will discuss in the post-operative. I have made a separate presentation for the post-operative part, to tell you details of all those. Want to show something regarding the frontal sinus. Hello. Hello.
Hello?
Hello.
Yes, sir.
Yeah, this is to discuss certain things about the most difficult situations of the frontal sinus. What you have seen in a revision frontal sinus is the simplest procedure you can think of. The simple draft to be on the same side. We have discussed modifications of the draft, so many modifications, modified subtotal, modified Lothrop, modified mini Lothrop, hemi Lothrop, central Lothrop. So once you have a persistent sinus disease, these are the options. In order, either do a revision procedure like what you have done earlier and revise it thoroughly, or do a draft procedure, modified endolymphatic Lothrops. Open counterpart for that is osteoplastic flap if you are not able to do endoscopic procedure, or if Lothrops is not indicated, then osteoplastic flap. Osteoplastic flap means you have to come from outside with a bicoronal incision, remove the anterior wall of the frontal sinus, remove all mucosa, drill everything, remove all mucosa, block the frontal recess, and obliterate the frontal sinus with fat or something. That is osteoplastic flap and obliteration. That is required when your drainage procedures fail. Even your modified endoscopic Lothrops fails, or when the modified Lothrops is not indicated. So when it is indicated, see, in modified Lothrops or draft like you saw, you need to have a big frontal sinus to give wide drainage, otherwise it may stenose to some extent. In cases where you don't have a big frontal sinus, what you can do, that will be easier for the obliteration and permanent answer. Osteoplastic flap should be considered in revision procedures when you don't have a big frontal sinus, when you can easily demucosalize it, remove all the mucosa and obliterate it forever. If you try to do that in large frontal sinuses with a lot of convolutions, convexity and scallopings, it is very, very difficult to remove the mucosa in entirety, and then obliteration is not indicated. In such large frontal sinuses, if you take up obliteration, you may not be able to clear the mucosa thoroughly, and if you try to obliterate, it can lead to mucocele further if the mucosa is left behind. So that is easier in sinuses which are smaller. So in those difficult sinuses, revision surgery is done, fails, revision again and again. You can take up osteoplastic flap if the sinus is small, if the sinuses are small. Even if your osteoplastic flap is done somewhere and still giving problem, mucosal and all that, if the sinuses are big, you can do a revision draft 3. So both the things are possible according to the need. So by and large, for the smaller sinuses, obliteration. In revision situation, even the draft fails. Primary is draft for everything. If smaller fails, osteoplastic fail. Otherwise, you can revise the draft 3, or in the most difficult situation, like I am taking up the next case, there are 2 procedures which are, eliminating procedures. Eliminating means you have to eliminate the frontal sinus to give problems in future. There is no frontal sinus in future, no problem. Kind of cranialization means the posterior table of the frontal sinus separates from the cranial cavity. If you have disease where the posterior table is deficient because of the disease, you can remove the entire posterior table, demucosalize the sinus completely, obliterate the frontal drainage pathway below, and allow the dura and the cranial cavity to expand until the anterior wall. So the frontal sinus will be eliminated completely There is no question of problem in the future. So that is required when your multiple procedure fails and the posterior wall is deficient. That is cranialization. The frontal sinus becomes a part of the cranial cavity. You remove the posterior wall and allow it to expand to the anterior wall. That is cranialization. Converse to that, if your anterior wall is deficient, gone, and frontal sinus is difficult to do, in spite of all procedures, still giving problems, remove the entire anterior wall, drill away all the mucosa until you get the normal bone so that you can remove the mucosa and all, osteitis and all bone, and allow the facial skin to fall on the posterior wall. That is facialization. You have to block the frontal outflow. And in order to prevent deformity, outside deformity, you can use bone cement or something to line for the camouflage, and the skin can come over it. That is facialization. This was described by Riddle, long back Riddle's procedure, it is commonly known as. So, according to the most difficult situations of the frontal sinus, you may have to take a call of cranialization or facialization to finally eliminate the frontal sinus to give any problem in future. So these are all the procedures. One or a front endoscopic surgeon must be, keeping in the armamentarium such procedures which can be of use, and we have done a couple of such earlier in our practice because they require such kind of approach. Now coming to the next case. See this is a little complex, more complex than what we have seen earlier. Say this lady who has undergone sinus surgery earlier. This particular patient, I'll show you in all planes what a complex situation. This patient has undergone sinus surgery. See, the rest of the sinuses are all good. Can you see? Hello? Is it visible? Are you getting the scans?
Yes, sir. Visible, sir.
See
Yes,
now
sir.
when I am going anteriorly, what is happening? See posteriorly, all good. Now coming anteriorly, see the same story. See the cells in the frontal recess, can you?
Yes, sir.
Yes, sir.
And now as you come up, see, because of the pressure or erosions of the frontal sinus walls all around, erosion looks like osteitis also with neoosteogenesis because of the ongoing persistent inflammation. See how the frontal sinus walls have become neoosteogenesis. See this?
Yes, sir.
Erosions of the wall, and this is the picture of the frontal sinus of this particular patient, which is giving her highest level of trouble. And this is the case should be dealt with very, very effectively by a more extensive approach, since it is bilaterally involving both the frontal sinuses with most complex issues of neoosteogenesis, obliteration of the outflow, erosion of the surrounding walls. And see, I show in all planes. This is one of the most complex situations one can think of. See this? If you see the frontal sinus, one by one in the sagittal, see if I change the window setting. See, this is the bone which is gone, and see the inflammation in the frontal sinus. See the osteitis, neoosteogenesis. All this is going on without intracranial involvement. This bone is gone. Opposite side also the bone is gone. See, at times the anterior wall is also eroded. At places the anterior wall is also eroded. So all around it is massive destruction of the walls because of the ongoing persistent frontal sinus disease, which is not, cured by the previous treatment because of the, what I believe is the inadequate work, inadequate widening, inadequate cells removal in the frontal recess, and the complexity of the disease, the inflammatory profile, and all that contributed to this. Now, what can you do for this patient? Anybody?
Lothrop.
Revision, same sinus surgery, same revision sinus surgery. Can that help? Big
No,
no, big no, because this has given such a huge osteitis, neosteogenesis. This requires a thorough irrigation post-operatively, which is not possible through the narrow opening now. If we try to revise, it is bound to fail. So now it requires a bigger procedure, complete marsupialization. The first try should be modified endoscopic Lothrops to regain the drainage again. The issue is to gain the drainage and delivery of the medications, the topical steroids, further by removing the floor of both the frontal sinus. We'll remove the floor of both the frontal sinus completely so that our topicals will reach effectively inside everywhere in the frontal sinus. So that is our first procedure. Let's see what it turns out to be. Don't frighten with these bone erosions that can happen because of the ongoing disease. The bone erosion and neostenosis both are part of the, inflammatory process, and that can happen. Let's see how the drainage, gives the avenue for the topical access, and that should give her a big relief, and the pathology can subside. If you find something beyond, a lot of posterior wall is eroded, you have seen in this case, and if it demands further any kind of the treatment, we can think of elimination procedures later on. So I have kept an option of elimination procedure for this particular patient in case required for future, because this disease is so massive, and we have to do something definitive. The first attempt in any given situation, such cases where the frontal sinus is not so small, it fulfills the criteria of a draft 3. See, the frontal sinus is big enough for the draft 3 to be contemplated, and a drainage process is re-established. So there's a good case for the draft 3. Headache. Tears, headache, and that is a massive presentation. See, I told you, primary sinus surgery, untreated sinus surgery rarely gives headache in spite of the complete whiteout. Yeah. Fine. But a revision, once you give this kind of a picture, is block because of the previous surgery, iatrogenic blockage, iatrogenic drainage blockage, they become symptomatic.
sir, do we?
Hello?
Sir, any CSF leak to be expected?
No, not at all. This is not herniation of the brain as well. No herniation of the brain. For that matter, you see the window setting change. See the bony wall is thinned out, very thinned out, but it is there. There is nothing herniation from above. We change the window setting, you get a lot of things. You can additionally get MRI if you have a doubt. See, you can see the thin bone. Still, you can see the separation of the cranial cavity from here.
Yes.
The issue is, see the anterior wall, big anterior wall erosion, posterior wall erosion. Everywhere, there's a massive situation. And now it requires a definitive work. This has developed even a small periosteal sort of, inflammation outside with a bulge because of this ongoing inflammation that the anterior wall eroded. I will show with the endoscope. Lamina pepracia. Another question from here by Dr. Islam from Egypt. See this. See, by the previous surgery, this lamina pepracia anteriorly is gone. See this? You have to be careful. But see, our draft or drilling is above the level of the orbit. So you don't worry. See, the orbits are here. And drilling for the frontal sinus is all above. But you have to keep in mind, charger लगाओ. Where's the charger? चल नहीं रहा है. दूसरी जगह लगा इसने। Yes. So this is the picture of this patient. It's a massive disease, and this could be something else. If it is, you have a doubt, must get the MRI done. Though we don't have a MRI for this patient, since it is a previously, sinus surgery patient with purulent infection coming. But yes, additional MRI would have been more useful, no doubt about it, to rule out, just to rule out anything. No fever, nothing.
Sir, biopsy is needed pre-operative.
No. Why? If it is inflammatory disease, infection, superadded infection, why it is going to help you? So case is ready, and we'll go ahead with that.
Sir, the cribriform plate is fine or it has some cribriform plate in this case?
Yeah, cribriform is fine. That is, I mean, the bone erosion is there. Definitely bone erosion is there. See this?
Yes.
See this? It is
Yes.
fine, but because of the bone resorption,
Yes.
bone
But there is
resorption and neosteogenesis, both things are going on.
But no history of CSF leak or something. No?
Nothing. This is not,
Nothing.
this is non-invasive disease.
Yeah.
It can give expensile bone erosions, can give neosteogenesis, bone resorptions. Bone resorption is due to periostin. Elevated level of periostin results in bone resorption.
Those biofilms or something that
Must
we
be
were
there.
talking about. Yeah.
Must be there. In such massive diseases, you can expect.
Yeah.
यार फूल आ रहा ना बड़ी मास्क फूला के बाहर से दिखा ना वो ऊपर बाहर से फोटो दिखा अरे ये ऊंचा कर गाउन दे दे आ जाओ गुड कौन सा बचा है उनमें से भवानी दिखाऊंगा बाकी तुम बताओ भवानी कर देंगे डेमोन्स्ट्रेशन एक साइड बाकी तुम फटाफट के मतलब अलग तुम 3 लेवल पे लेके सबको एक साइड करा दे मैं निकल जाऊंगा उसके बाद निकल दूसरा
ये भी टूट जाए टूट जाएगा वाला भी अच्छा रखा है यहाँ पे कल वाला भी रखा है
नहीं वही चल जाऊंगा आप इसका एक साइड थोड़ी रुक, इसका एक साइड कर दूं फिर करना। 10 मिनट बात कर देना। नाड़ा खुल जाता है मेरी नाड़े।
क्या क्या लोग आप करोगे?
देखना वो
थोड़ा 10 मिनट बाद बुला लेंगे एक
हाँ 10 मिनट। एक्सटर्नल कैमरा भी लगा देना। हेलो
Hello?
हेलो
Yes, sir.
Hello? Yes, sir.
यस सर, so we are starting the next one soon.
Just one external picture, sir. Everybody wants big demand for external picture, sir.
Are you getting the change to endoscopic picture, please?
ఆన్లైన్ మార్కెటింగ్ చేస్తారండి గూగుల్ మార్కెటింగ్ మరి ఈ నంబర్ ఎట్లా తీసుకొచ్చి వేరే కన్సల్టెంట్ పంపిస్తారా ప్రిపరేషన్ అడుగుతారు మీరు ఫోన్ పంపించండి ఒపీనియన్
Hello. Hello.
Hello? Hello?
Yeah.
Yes, sir.
Are you getting the endoscopic picture?
Yes, sir. Yes, sir.
Now see on this
Everybody-
side. A reasonably good job has been done to all the sinuses. See this? The maxillary
Yeah.
sinus, the sphenoid, that's the posterior artery, skull base, that's the stump or terminate. But see, the frontal area is completely, see the purulent discharge coming from there. But this is completely fibrosis happened. It is completely blocked. So where will the
Yes, sir.
secretion go? The secretion, because of non-drainage, is giving problems in the frontal sinus and the walls are eroded. Now going to the opposite side, see this. See the purulent discharge? See the purulence coming from the frontal sinus side, see that?
yes sir
And this side was probably not addressed previously. See this? So the problem is massive. The frontal has no drainage, giving massive erosions also. And this requires a big approach, and the ideal treatment for this is draft 3. See this, because of the ongoing inflammation, here developed
Okay.
inflammation in this region as well, because the anterior wall is going. Can you see?
Yes, sir. Is she
So the-
diabetic or what, sir?
No, not diabetic. So the procedure required now is a draft 3. What you have done earlier in the previous case, what you have done was draft 2. Draft 3 will address bilaterally along with removal of the upper part of the nasal septum and intersinus septum. So it's a more radical approach, yet functional because it establishes the ventilation and drainage of the sinus.
Yes, sir.
So-
Sir,
Yeah.
do you think this problem is developed because of using conventional instruments in doing FESS?
No, it's
Post-operative,
not.
like-
Or it's not because of the instrument. It's not the fault of the instrument.
No, previous surgery.
Yeah. How can you say the instruments were at fault?
No,
It is
like
the
I'm not.
frontal sinus not properly addressed.
Okay, sir.
And this is the biggest problem with the surgeons dealing with the frontal sinus, a fear factor of giving problems, ultimately ending up doing a inadequate job. If you are doing inadequate job, it can invite bigger problem in frontal sinus. So these are iatrogenic issues, which is bigger than the previous problem presented with. So frontal sinus, you have to be very thorough. That's why this session is totally, dedicated to the frontal sinus. And all of you who are doing sinus surgery must be able to do all these draft procedures. Once, like in the previous case, you have seen draft 2. If you know draft 2, you can do draft 3 as well. No need to refer such cases to anybody if you are doing a sinus surgery. That's the goal. You can do it. You ask me 100 times, any point of time you find any difficulty in executing surgical procedure here. See thoroughly each and every, surgical step. Interrupt me anytime. Bottom line is you should be able to do it in future. नहीं वो. Now see, coming to the right side first, which is not operated earlier. See, I tell you one of the steps to see this. This septal deviation has pushed the turbinate and given a paradoxical look. This happens many a time you see in sinus surgery. And one of the ways is the microfracture. How can you go give microfracture to the turbinate? See, not superiorly where it is, inferiorly at this level. See this, what I am giving, this is microfracturing. This is microfracturing. You cannot appreciate, but you can feel the crack. You don't see any crack on the surface, not superiorly, because superiorly turbinate is attached to the biform. See this microfracture I have given, which has stabilized the turbinate close to the, septum. This is simplest way, microfracturing, and in our clinical practice, 90% of the time we get away without doing any bolgerization or turbinate removal. Just microfracture, push some Merocell or something for a while and you can stabilize it. And at the end of the surgery, again, you can put some Merocell or something in the cavity for 1 or 2 days like this. Are you getting PIP? Hello?
Yes, sir.
PIP of the external picture?
Yes, sir.
So anytime
Sir,
What?
your assistant is standing behind you?
Besides me, if you want
Okay.
the PIP to be bigger, you ask us anytime, tell us. We'll enlarge the PIP to show you. Enlarge once. ये दिखाओ इधर इधर है, गुरु. Hello.
We want to see your
अरे,
position, your
दोनों को
assistant
दिखा.
position and camera.
छोटा कर हाँ.
Yes, sir.
Can you see?
Yes, sir. Yes, sir.
So my assistant is besides me. See, he is using suction.
In the left hand.
Yes. And now see what the microfracture has given. Stabilize the turbinate close to the septum. Can you see this?
Yes, sir. Yes, sir.
This microfracturing, first of all, should be done below, not superiorly. Don't do anything to the turbinate superiorly where it is close to the premium. And it should be microfracture, not obvious fracture coming to the surface. See, the surface is normal. Only the bone is fractured inside. And you get a click. Once you do it, you get a feel. Okay.
Yes, sir.
Okay?
Okay, sir.
Like that.
Sir, where is the trolley, sir? Trolley is behind your assistant.
Yes. There's one more assistant with a trolley besides him.
Okay. Okay, sir. We are asking very basic questions.
Yeah, it's important. See the opposite side, nothing was done earlier. Okay? He has a
Yes, sir.
bilateral frontal sinus disease with intersinus septum eroded.
Yes.
That's a basic situation with us. This side done with complete fibrosis. See this? Complete fibrosis. The septum, see the remaining turbinate is fibrosed with the lateral nasal wall. And this side, even the lamina papyracea is destroyed during the previous surgery, if you remember. On the CT scan I had shown. Remember?
Yes, sir. Yes, sir.
Adding on to the challenge.
On the lamina on the left side or right side?
What?
No, left eyeball or right eyeball? Lamina. Lamina.
Lamina left side.
You're doing now on the right side. No?
Left side.
Achha, left. So what care do you take, sir, at this point? Lamina not to breach.
Yeah, we'll find frontonasal process and accordingly follow it up. Work more and more superiorly, first of all. The lamina is that way left below.
Sir, should we try to look for that olfactory neuron in this case?
Yes, always.
On.
See, there is another approach. Another approach that is described as outside in approach by Richard Harvey. Outside in means, see, I'm showing with the 70. Outside in means you, rather than starting from the frontal recess side, you can start from the frontal sinus side above. When your frontal recess area is difficult to identify, you can come from above, frontal sinus side, and then follow it. I mean, you go anterior to the first olfactory neuron first, open up the frontal sinus, and then extend your surgery down. I can feel the bone here. I'm more and more anterior. So much of fibrosis everywhere. What I'm trying to identify is the frontonasal process. First. That's the level of the middle turbinate. See below. Following it up, and working right anteriorly onto the frontal sinus. Just defining the level. With a lot of fibrosis, lot of, bone destruction, sometimes make your life difficult. So, be careful. This is this side. Let's go to the opposite side for a while. Just leaving for a while. 0. Hello?
Hello, yes, sir.
Yes, sir. This is for orientation. Now going to the opposite side. Just, I'm trimming this turbinate here. This is wedge resection of the turbinate. My stump of the turbinate is visible. And now we have good landmarks. See the same bone exposed like previous case. Could you see? That's the upper part of the septum.
वो खाली सेक्शन रख दिया अंदर नीचे लेफ्ट हैंड से उधर चले गए लेफ्ट हैंड से पानी डालो
Upper part of the septum removed by gallbladder itself, and you see the marrow cell from the opposite side coming. See the marrow cell from the opposite side coming. That's the upper part of the septum. See the septal window? That's the septal window in the most superior part. Hello?
yes sir
That's the uppermost part of the septum. See the pus coming out. See that?
yes sir
Which is collected there under pressure. That's the frontal drainage pathway on this side. See now, orient yourself. This is the turbinate, stump of the turbinate below. That is the stump of the turbinate below. I am above, and that was the frontal drainage pathway on this side. That is the interior of the frontal sinus. Just for the orientation. That is a remaining intersinus septum and the opposite sinus at this level. See the opposite sinus at this level.
yes sir
This sinus, this is below, and now is the time for removing this bone. To get rid of this bone, drill. Yeah, just all 0 degree. All 0 degree. See the outside anterior wall bone is also destroyed, so you have to be little careful. So now I have oriented myself with both the frontal sinuses. Some purulent secretions came out.
so that
Starting
inflammation
from, yeah, incipated secretion, blocked sinus, invite secondary infection. See, starting below. Same kind of drilling on the right side. I started below.
yes sir
And I have reached the level of the skin. See the outside skin level. This is the outside skin level. See this?
Yes, sir.
And now I am removing this all bone, remaining bone. Part of the bone is already destroyed. तो पानी कम कराना.
Sir, will there be any external deformity because the bone be removed to the skin later
Pardon?
on post-operatively? Sir, will there be any external deformity because bone being removed up to skin?
Can't say right now because
But there's a possibility.
yes, that can be corrected once it's disease free. Later. See now.
Yes, sir.
Let me show this area what I've drilled. This is outside skin. This is outside skin and subcutaneous tissue. See, all this is outside skin and subcutaneous tissue anteriorly divided. And what you see there, this is all disease in the frontal sinus. See, now I am in the frontal sinus.
Yes, sir.
See the mucosa, how it becomes so hyperplastic.
Yes, sir.
Bad disease.
This is RAD 120 or RAD 40 blend?
This is red 40. I am in the frontal sinus, you can see very well.
Yes, sir.
Now let me show this frontal sinus with a 70. See the pus removed from the frontal sinus. See the interior of the frontal with this mucosa. Thick, fibrotic, hyperplastic. See this frontal?
Yes, sir.
Now see, this is the outside skin, this is the anterior skin, this is the interior of the frontal.
That is
Can you see the
supraorbital.
frontal? Yeah, not big one. See this frontal from inside?
Yes, sir.
Reverse. Nice frontal sinus. With this, now it is draining, you know.
So you will leave this mucosa?
Yes, it should revert.
Adenoid blades.
Yes. See the frontal sinus in detail. And that's the limit also. Anteroposterior depth is not much. See this? That's the limit with the flush with the skin. Can you see?
Yes, sir.
You cannot remove any more bone from the anterior wall from here.
It's the neuron first also.
Is behind. First olfactory neuron is behind.
Sir, are you planning to remove this intrasinus septum or leave it?
Yeah, we will remove. See, at the same level, you expect the opposite side. This was here. Since opposite side, the landmarks were not clear, so I came to this side first, which was better in terms of showing the landmarks. Okay.
Okay, sir.
Now, Ani,
Burr. Sir, size of the burr, sir?
same 4.5 mm coarse diamond, using at a 75,000 RPM.
Sir, external camera, can you please zoom slightly?
Yeah, please.
We want to see the left hand, right hand movement of the assistant.
Yes.
Yeah, that's enough, sir. Thank you, thank you. उसका left hand अंदर ही है.
See the opposite sinus.
Yes, sir.
That's the intersinus septum reduced. See the opposite sinus.
Yes, sir.
Why I did not go from the opposite side? The same fear, because the orbital part of the bone was removed. Landmarks were not clear. Later.
Sir, Mr. Ramesh Chand is brilliant as always. He's doing wonderful job.
Yeah, so you have to develop your assistant also to make your life easy, because becomes your, active assistant rather than being passive assistant. You're right. See what the frontal sinus this lady had. Pardon? Pardon? No, that's not defect. The bone is gone. This is the bone where the dehiscent is. That's the level of the cribriform plate. That's the olfactory neuron here. And this bone above, see this? Hello?
Yes, sir.
This is the cribriform dura, which you are not supposed to disturb. You can
Right, sir.
walk anterior to it. I can reduce. Why I saw that? Oh, you know. So I can reduce this bone further. Honey. See this?
Right, sir.
I can give widening to the opening by means of further.
So this is the
So,
posterior table of the
this is
frontal.
posterior table. This is obviously posterior table.
Right, sir.
So in order to give more anterior-posterior length, which this patient has narrow,
Right, sir.
I define the cribriform plate and now widening it. Now see the condition of the opposite frontal recess. So
Yes, sir.
difficult it is to reach out. See that? This is
Right,
your
sir.
cribriform plate. This is your orbit, and your frontal recess, is there. Right. See, I'm clearing the opposite frontal recess now with much more orientation. Earlier was a fear of damaging the orbit, but now see all
Yes,
this
sir.
hyperplastic mucosa. See the opposite frontal recess cleared so confidently now.
Right, sir.
Oh, what's it? Frontal. See this? This mucosa I wanted to take for histopathology. This is the mucosa I have taken for the histopathology. See the frontal sinus. Now the frontal sinus is draining directly into the nose. Can you see?
Yes, sir.
For this surgery to remain successful, you have to ensure that this remains patent. You know?
Yes.
So you have to be very aggressive in post-operative follow-up and douching that this keeps on draining because the anterior posterior depth is narrow. See this?
Yes, sir.
This is graph 3. My limit, I cannot remove the bone behind. See this? The cribriform has come. That's the mucosa. You cannot remove this bone. Outside the skin has come. See this? Everywhere. You have reached the limit. Give me the drill. Little bit. छोड़ दिया ना यार रुक जा यार चल क्या कर trying to give more anteroposterior widening if possible.
Sir, if during surgery anywhere we encounter CSF leak, so sir, what will you do in that case?
Yeah, you have a full access to the area now. You can repair. Rather, this is one of the preferred approach for CSF leaks from the posterior table of the frontal sinus. In that, you do the same approach. Once you can access the site of the leak, you have to repair like anywhere you repair. It is the access which matters. And now with you have a full access, you can repair same way. See the frontal sinus on this side.
Yes, sir.
River. And now I am sure this patient will do really well because a good drainage is established. Yeah, we can leave it. And only thing, this will require very, very thorough irrigations because of the ongoing osteitis, raw areas. Now this is exposed to topical steroids well and will require a good topical steroid drainage. Now back to 0 degree to show you the final picture. See the septotomy, you should be able to see the opposite frontal recess from the opposite side. See? You should be able to work in the opposite frontal recess from the opposite side. See that? This is your scribiform plate. And see the wide drainage of the frontal sinus. Can you see? With the 0 degree now.
Yes, sir.
And this is good enough. We will pour more and more, steroids, train her into, thorough irrigation. See now the steroid will now able to reach deep into the sinus very well. And this drainage, if remains, is a cure to this patient. Thank you.
Thank you, sir.
Thank you, sir.
So that was one of the complex areas, I would say, needed to be addressed. So first we demonstrated draft 2. This was a draft 3 for the appropriate indication. There are more complex areas in the frontal sinus, sometimes. Can you connect? वो बंद करो. Reaching in the depth of the sinuses. इसको कनेक्ट करो. जा रहा है? हेलो 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 हेलो.
Yes, sir. We can hear you.
Okay. So, are you getting the computer screen there?
Yes, sir.
Now, I show you some of the most complex situations for the frontal again. And for that, endoscopy is the answer. Nothing else can work. Even the open approaches are, I would say, contraindicated. And that is one of the situations. See this. This particular patient has a pen sinusitis bilaterally on this side, right side, because of the blockage at the narrow frontal drainage, the mucocele collected beyond, and because of the expansile nature of it has eroded the orbital roof, the floor of the frontal sinus, and the posterior table, and it is expanding and expanding and expanding, giving this kind of a proptosis. Now, what is the answer to such problem? This is such a difficult problem. Now, if you try to say, somebody says, this is contrast to show that this is mucocele, not enhancing. See this? Now, the question is, how can we address this? If you say open approach, if you try to do anything with the open approach, you can drain this mucocele. But how will you ensure the drainage of the sinus into the frontal recess? Impossible. So open approaches are contraindicated. The only thing which works endoscopically in such scenarios, see this narrow frontal recess. So what you need to do is do a draft 2 on this side complete, then drill the lamina pepraea medially behind until the anterothomal artery, remove the lamina pepraea, and then keep elevating the periorbita from the lamina and the frontal bole above, and push the eyeball laterally and keep removing this bone. Separate the eyeball and separate this roof bone or floor of the frontal sinus bone above the eye to remove it completely to give a wide drainage there. This is called endoscopic orbital transposition. Again, this bone, this superomedial bone has to go. Orbit should be pressed laterally and separated. This periorbita should be intact all the time. Remove this bone, give a wide drainage. This mucocele should drain from here, and this drainage should remain forever. That is the need for such patients. Anything else than this is not going to work. If you do open approach, to me, it is contraindicated. Another example of this. Another example for this, we have number of cases for such orbital transposition where nothing else can work. See this again. See this again in this particular patient. See this again. Massive case. See this frontal sinus drainage is blocked. This has given away laterally. the orbital roof or the frontal floor is destroyed, posterior table destroyed, and see it is expanding and expanding there because the drainage is not there. So answer is do a draft to remove this superomedial orbital bone. See, this is the culprit. Remove this bone, protect the periorbita and push the periorbita laterally to remove more and more this part of the bone to make it draining into the nasal cavity. This is called orbital transposition, and this is the only answer for such problem. Even if you try to do anything from outside, this is not going to establish the drainage into it. So the culprit bone is superomedial, and the answer is the orbital transposition. So these are the cases, ideal cases for orbital transposition. So this is something, another situation we must be well versed with and should be able to justify surgery in such a case. Now see, this patient, I gave you yesterday an example of the patient who presented to us with bilateral blindness, complete blindness. See this. First, let me show you what the finding is. Yes. See this. See this. Coming from most anteriorly. See the frontal sinus. Heterogeneous hyperdensities, allergic fungal rhinosinusitis, bilateral, complete frontal bone destruction. Now the brain is coming behind. All this is, expanded frontal sinuses with all surrounding bone destroyed, completely destroyed because of the pressure. Now, going behind, see the supraorbital cell. Now, this is cribriform plate. What this you are seeing is a supraorbital cell, and the fungus occupying the supraorbital cell till far laterally. See this? Far laterally. Going behind, this is posterior ethmoid, all eroded. Everything eroded, now going in the sphenoid, and see this is the optic now on both sides, embedded in the fungal mass, embedded in the inflammatory mass. See this completely embedded in the fungal mass and presented with bilateral blindness. The moment we got the scan done, it was AFRS and started high dose steroid, itraconazole, and immediately planned for the surgery. And this entire fungus, everything removed, full dose steroid and antifungal given for few days to reduce the inflammation, and this patient recovered completely. Complete recovery of the vision was there in this patient. So this, how these, sometimes the AFRS present so massive. There are a variety of AFRS situations. Sometimes they frighten but don't get frightened. These patients, see this another patient where the draft was done. See the condition of the frontal sinus. Bilateral, intersinus septal destroyed itself. I see the heterogeneous hyperdensities. Intersinus septum destroyed, bilateral. See this supraorbital cell, and this is the supraorbital cell where this fungal material is there, and it is ballooning with posterior wall destroyed. This is supraorbital cell. This is cribriform plate. And see this ballooning of the supraorbital cell and complete destruction of the wall. Frontal is anterior, beak is there. Now I am going behind. Behind, the beak is gone now. This is frontal recess. This is frontal recess. This is supraorbital cell on this side. See the opposite normal supraorbital cell. So that kind of picture, see sometime, which frightens. And actually these are good curable cases, treatable cases, which we must know rather than getting frightened because of the, this expansile nature of. So many a times you get such, presentation of AFRS, funny, extensive presentation of the AFRS, and can give a good, reasonably good job. See how the maxillary sinus is widened. See this massive unilateral young patient, probably 8 or 9 year old this patient was, exceptionally, see, complete unilateral disease with bilateral involvement of the frontal sinus because of the pressure the frontal sinus completely eroded. So you may get variety of frontal sinus situations in these AFRS patients. Another patient with massive disease in the sphenoid sinus. See the sphenoid sinus with complete lateral recess involvement. See the pterygoid process is pneumatized, the lateral recess, and this fungus is occupying the lateral recess, bilateral sphenoid, yet the disease unilateral. The primary disease is unilateral because of the destructive nature, the septum, intersinus septum destroyed and involving bilateral. So you have seen in a unilateral disease, bilateral involvement of the sphenoid and bilateral involvement of the frontal sinus, yet disease being strictly unilateral. See the opposite side, ethmoid, maxillary, post-ethmoid, everything is uninvolved only because of destruction of this. Because the sinus is blocked, it cannot drain and destroy the intersinus septa. See, that's a various funny presentations of this fungus. Now, there are 4 types of fungus. If you see in aggregate, the variety of fungus, this was another one. 4 types, 2 varieties of non-invasive and 2 are invasive variety of the fungus. And we should be able to differentiate pre-operatively, so you can target your treatment accordingly, which is desired. Let me show you what I'm trying to say. This is again, see this massive presentation of the fungus in the frontal sinus. See this heterogeneous hyperdensities, and see this is ballooning in the supraorbital cell. Ballooning in the supraorbital cell. If I reconstruct in all planes, you can see that. See this fungus in the sagittal plane, it is so ballooning, pushing the dura behind, ballooning. See this fungus, all fungus material in the frontal sinus. This is frontal sinus above, and this is the supraorbital cell, which is ballooning up. So there are a variety of situations, funny situation you may come across. So what I was trying to say, there are 4, variety of fungus situations one can come across, 2 non-invasive and 2 invasive varieties of fungus. Now, which is how to differentiate between the invasive and non-invasive, and how to differentiate if the fungus is existing on, radiology. On CT scan, you can see the heterogeneous hyperdensities, but in certain situation, even in the such sinonasal situation, you need MRI. Right? MRI is so informative. So when the MRI is indicated, we have seen since yesterday only CT. Only when the disease is extending beyond the confines of paranasal sinuses, when you have doubts on diagnosis, if you have something doubt on the existing diagnosis, confirm with the MRI. Or when funny presentations in immunocompromised patient, there could be somewhere more extensive disease beyond the confines and which may present as a surprise later on, and MRI can clarify before you start your treatment. And once you have sometimes unusual symptoms, which is not, justified by the present CT scan, you can get MRI done. And once you have something, complicated, intraoperatively, postoperatively, or preoperatively, patient presenting with complications, you can get MRI done. So there are indications for MRI for fungus particularly. Let me show you. See this particular patient. See this on CT scan, a patient present like this with erosions of the walls of sphenoid. This frightens the surgeon. Just to give you an example when MRI is indicated and help you solve the problem. See this, it looks like could be some tumor. CT cannot differentiate in the soft tissue masses, Now, if you bring in the MRI, see this. What is this? On T2 weighted MRI, the bright picture is the fluid, and there's a classical picture of a mucocele. This is classically a mucocele.
Yes, sir.
Which has destroyed the walls of the sphenoid, bone of the sphenoid, because of expansile nature. And the answer is very simple. You open up the sphenoid and marsupialize it. On CT alone, it looks frightening, but it is actually a simple problem. So these are the indications where the MRI can solve your problem easily. Now see, there's a patient on CT scan, looks like CT scan, all opacities look same. See here, nothing concrete you can make out with a CT scan, but when you bring the MRI, now see, the same T2 weighted MRI, the fluid is very bright, and which is not enhancing is a tumor. So in those situations, rather than getting intraoperative surprises, when you are in doubt, you can get the MRI done to reach to the correct diagnosis. Many a times, many tumor present like this, inverted papilloma behind, many other benign tumors behind. Anterior nasal endoscopy, some mucosa prolapsing, looking like as a polyp, and case is taken up for sinus surgery, and it turns out to be a tumor behind. With a good scan, with thoroughly seen scan, giving you suspicion, can direct MRI. Can make you order an MRI, and which can clearly distinguish what exactly it is. Fungus. See this. On T1 weighted MRI, how you can differentiate in a non-invasive situation like sinusitis, AFRS? How can you be very sure that this is fungus? 100% sure of the fungus. See this. This is fungal disease. On T1, it is hyper intense because of ferromagnetic component. See this. Fungus is hyper intense on T1 weighted, and T2 weighted, it is signal loss, dark. Wherever fungus is, on T2 weighted, it is dark. On T1, it is hyper intense. See, you can easily distinguish. MRI, the investigation of choice for the soft tissues, and this is how you can clearly become where the fungus is.
Sir, we need to ask them for T1 weighted, T2 weighted separately, or?
Always. See, your question is very valid. If you ask the radiologist MRI PNS, you know what we'll do? MRI, every sequence has to be shot separately, not like CT that you can reconstruct easily. In CT, we ask simple 0.5 mm, 0.625 mm axial sections, and then your software will reconstruct, not the MRI. MRI has a versatility of giving n number of sequences, and every sequence has a value in giving some or other useful information. Every sequence has to be shot separately. In every plane, like T1 weighted MRI, you have to shot separately T1 axial, T1 sagittal, T1 coronal, T2 axial, T2 sagittal, T2 coronal, T2 FET suppress, axial sagittal coronal, contrast axial sagittal coronal, diffusion weighted, 3D flares, drive imaging, so many. So if you write only MRI PNS, the radiologist will finish in 10 minutes giving you 1 or 2 sequence MRI PNS. That's it. Without doing all those sequences, it takes time. With a proper MRI, we want, like we prescribe in our format, that we want T1 multiplanar, T2 multiplanar, T2 FET suppress, contrast, drive, diffusion, there. It takes more than 1.5 hours, and it costs also. So the onus is on the surgeon to acquire proper information is to write what sequences are required. So whatever you are suspecting, accordingly, order the MRI. Otherwise, you will, in spite of getting the MRI, you're not going to get the desired information. Now see, or T1 weighted, hyper intense on T1 and signal loss on T2. This is nothing else than fungus. I hope it is very clear.
Yes, sir.
Now, I'll give you certain examples of fungal sinusitis. See this again. See this again on T1, full of disease, and T2, absolutely normal. Like there is no disease. In this setting, if the patient's T1 MRI is not done, suppose only T2 weighted, you will see there is no disease, which is full of fungus actually, because T2 is showing signal loss. Got my point? In situation when you don't have adequate imaging, you can be in big trouble. A complete signal loss on T2 like there is no disease at all. It's full of fungus. So there are 4 varieties of fungal situations. 4 varieties. Non-invasive, invasive. The simplest among non-invasive is the fungal ball. We call it fungal mycetoma, where fungus somewhere on inhalation trapped in one of the sinus. But patient is not allergic to it, so it is not giving any reaction. Because of the non-drainage, the fungus is accumulating there and you may find the sinus full. So most of the time you will find isolated sinus involved. अभी देखते हैं, बुला के दिखा दे मेरे को. कैटा वो बोलने लगा है, मेरे को देखो. So one of the sinus is involved and not giving any problem except when it is completely blocked and give some symptom. And the answer is just open that given unilateral sinus rather than doing an entire full house FESS or something, because this is localized disease, non-reacting, that is fungal ball, non-invasive. Second is allergic fungal sinusitis, which we have been discussing since yesterday, is a different endotype with massive allergic reaction, eosinophils coming into the action and giving that classical picture of, heterogeneous hyperdensities, bone erosion, massive, extra sinus involvement, pushing the borders, not invading. Then our invasive fungal sinusitis, which are broadly divided into 2 categories, acute and chronic. See, this is allergic fungal sinusitis. Now, see, this is so many bone erosion this is giving, but yet it is non-invasive. What is invasive? Chronic invasive? You will see minimal sinus disease and more extra sinus disease. See this, minimal ethmoidal sinusitis, but the disease is going inside the orbit. Bone defect at that site. Minimal sinus disease, bone defect at site and going intrasinus, extra sinus somewhere, orbit, infratemporal fossa, or even see this, minimal ethmoidal disease and a complete orbital apex involvement presented with blindness. And this was chronic invasive fungus. So this is a different variety you should be able to pick up pre-operatively, because it is the right diagnosis which can take you to the right treatment line. Reason being, in non-invasive fungus, antifungals are not needed. Fungal mycetoma, allergic fungal sinusitis, antifungals have no role. But in invasive, here the treatment is different. You are not supposed to remove this fungus completely. Unlike allergic fungal sinusitis, where every fungal antigen, fungal particle has to be removed, that is serving as an antigen. Here, like this, even in spite of here, you don't need to remove this entire fungus. Once you suspect chronic invasive, the role of surgery is limited to confirm the diagnosis that the fungus is invading the mucosa. Just a biopsy. If some sinus is blocked, establish the ventilation drainage of that particular sinus. And once the diagnosis is established, medical treatment is the answer and the voriconazole is drug of choice. That can kill this entire fungus. You don't need to remove this entire thing. It can clear all this very fast. So this is chronic invasive fungal sinusitis. This is a different fungal disease. See this, the sinus involvement is less, but the extra sinus disease is more. I'll give you some an example with additionally help from the MRI to direct more specific treatment. See here. See this patient. See this patient. See this patient. He had, now we
Yes,
have
sir.
proven with the biopsy. He came to us with this picture. We took a biopsy, suspecting chronic invasive. Turned out to be chronic aspergillosis, started voriconazole, and now everything subsided. You don't need to remove anything. Don't frighten with the intraorbital, intracranial, or anywhere involvement. You don't need to remove anything. Just open up the sinus. We open the ethmoid sinuses, establish their drainage. The frontal was already draining, only ethmoids were obstructed. And अरे बेटा के मनु कान भी लगाना है, दिखा दे मैं वहीं बेटा के. And then once the diagnosis is established, voriconazole has to be given as a treatment of choice to treat such patients. So chronic invasive is a different entity. Now finally, the most important entity we have discussed a lot during the COVID times is the acute fulminant fungal sinusitis, commonly known as mucormycosis.
Sir, for how long voriconazole has to be given?
Yeah, so that's a very difficult decision, but yes, that decision has to be taken on 3 grounds. So it has to be taken on 3 grounds. Number 1, the radiological grounds if the fungus is completely subsided. Clinical grounds if patient is no more symptomatic. Third is biochemical grounds. You have to, once you are treating, before you start the treatment, we get the galactomannan test done. Galactomannan is a protein found in fungal cell wall, aspergillus cell wall. And before you start treatment, you can, at the time of biopsy with this biochemical test, you can prove that this is chronic aspergillosis only where the galactomannan levels are high in the serum. And then with the treatment, you can monitor the galactomannan level. So the third is a biochemical, the galactomannan and the inflammatory markers like ESR and CRP, they come down. ESR is more informative as the CRP denotes bacterial infection, which is not there. So when everything comes down, clinical, radiological, biochemical, you can take a call. Sometimes you need to give 4 months, 6 months, 12 months, 18 months even. It depends. And you have to monitor with the liver function test. In certain percentage of cases, it is hepatotoxic. We have seen patients dying with a voriconazole because of liver failure. So you have to be very, very cautious about it. The fourth variety is this acute fulminant, that is mucormycosis. It's a different endotype, presents in a different way, very fast presentation as it invades the vessels preferentially. What shall we get on it?
Sir, can chronic invasive convert into acute one
Not
at any
really.
stage?
Not really. That's a different pathogen.
entity.
Different pathogen.
Okay.
This is the pathogen in mucormycosis, belongs to the zygomycetes family, is a different one. And it preferentially invades the vessel and blocks the vessel, giving due to thrombogenicity, it invades the vessel and give complications because of the vascular blockage, because of the ischemia finally to the tissues, and patient present with those problems. And see how you can pick up right from the diagnosis till final answer, till treatment. the thing which can guide your treatment thoroughly, perfectly is the MRI, contrast MRI. For two things. Number one, for diagnosis. You see the area which is necrose, which is not picking up contrast. See the opposite side taking up contrast, but see the turbinates, and this area which is not taking up contrast, that itself gives you the diagnosis. Number one, that this is mucor, which is given vascular necrosis. Number two, it dictates your surgical, extent of surgery. It's a medical disease, invasive fungus. Ultimately, treatment is medical, and here the treatment of choice is amphotericin B in liposomal form. But in the necrotic areas, amphotericin is not going to penetrate. If the gadolinium is not penetrating, amphotericin is also not going to penetrate, because it has to go through the blood only. If there is vascular necrosis, vascular occlusion, thrombosis, where the gadolinium is not going, your treatment is the medical treatment is not going to be effective. So the extent of surgery is guided by MRI, contrast MRI. Wherever gadolinium is going, even if there is fungal infection, the liposomal amphotericin will kill. But in the necrotic area, you have to debride as soon as possible, because this is the depot of fungus now. That is the environment which invites more and more fungus, and it's going to give further complications. So the MRI will tell you the extent of removal. See, in this case, even the septum has gone, septum had to remove, even sometimes the soft tissues have gone. If you leave the necrotic area behind, the medical treatment is not going to be effective. So this is something must keep in mind. The extent of surgery should be dictated by MRI here. If you leave any necrotic area, it is going to progress. See this example, we lost this patient. As the patient had a good vision, so we didn't treat the eye, and the eye had necrotic area, lot of necrotic area inside, and later patient presented with vision and cranial complication and died ultimately. So even if you have a good vision, if you find necrotic areas in the eye, maybe still the vision is intact, you have to treat it. It's not the vision as compared to the life. Life is more important. So see this particular patient. See, when it invades the soft tissues. Now, the soft tissue from outer appearance, outside appearance may appear normal, but yet showing necrosis inside. So if you don't remove, you see the nasal ala, soft tissues, all have to go to give this patient, to make this medical treatment effective. If you don't do that, you cannot cure this patient. So the
Sir,
MRI,
this is gadolinium MRI or?
yes, gadolinium enhanced MRI.
Okay, sir.
See this, the entire orbit is gone. You have to debride it. Anywhere fungus is there, see this fungus, you can remove all this, entire maxilla you can remove. But see this, the greater wing of the sphenoid, it is gone, and you have to remove this greater wing of the sphenoid. So this is very important to address all these issues according. So in mucormycosis, the treatment is entirely dictated by MRI. We have more than 800 MRIs from the mucor patients during that time, with variety of funny presentation, and MRI was life-saving to them. Quickly giving 2 or 3 examples, as somebody asked me in the dinner last night to tell something about the MRI. Sometimes you get a patient suspecting mucor. See this. This patient, in mucor, the sequence which is most important is the fat suppress. I tell you the reason why. This is very important to understand. This is T2 weighted MRI. See, one side is normal T2 weighted, one side is T2 weighted fat suppressed. What is difference? You suppress the fat. Suppress the fat on this side. Here the fat is appearing as a bright. Inflammation also appears bright. Now, how can you differentiate whether it is a fat or inflammation? On this side, this is fat suppressed. Now, whatever appear bright is the inflammation. See now. See now. In this is sphenoid sinus. That's the posterior part of the nasal septum. Now inside the sphenoid. And see now, even in the pterygoid region, infratemporal fossa, wherever there is hyperintensity, this is pterygoid process. This hyperintensity is all inflammation. Here you cannot differentiate in a normal T2 whether there is fat or inflammation. So T2 weighted MRI. This patient had normal endoscopic finding, diabetic, no other presentation, some, pain, vague pain. We got the MRI done and see the entire septum has gone. The sphenoid was full, pterygoid was full, infratemporal was full, and it was mucor. MRI can help you reaching the early diagnosis. There is no other way than MRI which can take you to the earliest diagnosis. This is a classic example. Let me tell you some of the classic examples how MRI can save you. This is something that even the radiologists, do not tell you. That they don't have time to go to that depth unless you ask. Now see, I am giving you certain classical diagnosis which can really help improving your diagnosis. See, this is the patient. This was again a lesson to us in the early phase. This patient had mucormycosis. Unlike other mucor, this was treated on the ground of mucormycosis. Again presented with the persistent problems. Then we got the scan done, reviewed the previous scan. And an interesting finding was what we missed was the early palatal involvement. See what I'm trying to say. This is fat suppress MRI. On fat suppress MRI, in the bones, there is bone marrow which is fatty. On fat suppress MRI, it suppresses the marrow. See this, like this is T1 weighted. Can you see the marrow? Which is hyper intense. T1 weighted shows wherever the fat is hyper intense. See this, wherever the fat is hyper intense, wherever the bone marrow, it is hyper intense. See this, T2 weighted fat suppressed, the marrow will not be suppressed. See the early alveolar involvement. Normal side, marrow is suppressed. Marrow is suppressed on both sides, but this is inflammation. This was the earliest involvement by the infection, mucor, which was not apparent on the surface of the palate. And later on, he presented with a surface lesion. We reviewed the previous MRI and we missed this finding and had to undertake a second surgery. So early palatal involvement you can pick up by means of a good fat suppress MRI. It can, help you pick up the early lesions. See this. This patient, fat suppress MRI. See this massive involvement of the infratemporal fossa, bilateral. Bilateral involvement of the alveolus. We had to remove the upper alveolus bilaterally. So your fat suppress MRI can tell you exactly what is happening. Take into account the T1 weighted. T1 weighted, what will show you? T1 weighted will show you. See this. In this patient, let me show you a normal T1 weighted and normal T2 weighted, so as to differentiate what should be the normal and what should be the abnormal. A normal. I'm showing you a normal MRI for this region. What should be seen on normal MRI? See this normal fat suppress MRI. Normal, these are the turbinates. ये हिल गया कहीं से देख. connection are loose. Hello?
Yes, sir.
Hello?
Hello, sir.
Are you getting anything on the screen?
Still picture we got.
Hello?
It's a
Are
still
you
picture,
getting
sir.
anything
Nothing
on
is
the
moving.
screen?
There is screen, sir, but still picture is there. Nothing is moving.
Is it going?
No,
Are
sir.
you getting MRI on the screen?
Yeah, yeah. Now it's moving. Yeah.
Yes. See now, this is normal fat suppress MRI where you see no enhancement, no abnormal enhancement anywhere. The fat is suppressed everywhere. Now, I am bringing normal T1 weighted MRI. See this. T1 will show wherever the fat is enhancing. See now, the fat in the cheek. See, classically this, the fat in the upper alveolus. This is the bone marrow of the upper alveolus, which is suppressed on T2 fat suppressed. Now, if on T2 fat suppressed, there is no enhancement. And if there is enhancement, that is inflammation. Suspecting mucor means here the mucor has invaded the alveolus. That is what you can pick up. Now see, how to see the further pterygoid bone involvement. See this. See the pterygoid process on both sides with the bone marrow. See the bone marrow. In a normal situation, you will find this bone marrow. This is T1. This is fat, which is enhancing the marrow fat. On T2 weighted, is this? See, this is dark signal because the fat is suppressed. Got my point? Now, whenever on T2 weighted fat suppressed, you find any enhancement, that means that is inflammation. That is what I wanted to tell you. Now, I'll give you a couple of examples, where you can see easily now on fat suppressed. Easily. See this patient. T2 weighted. See this. What is there in the alveolus and palate? Hello? See the inflammation. See the inflammation, and if you bring the T1 weighted together, you will see. See the marrow on the normal side? Can you see the marrow on T1? Hello?
Yes, sir.
Normal marrow on T1 and the opposite side marrow is replaced by infection, which you see here as a hyperintensity on T2. It confirms your diagnosis. You don't need anything else. It is so clear. It is so clear. And wherever there is necrotic bone, on contrast, if you see, you will not find any enhancement. Whenever there is necrotic bone. See this. This is necrotic bone here. See, no enhancement. This is necrotic bone because the contrast is not reaching there. And I tell you, in spite of being a medical disease, if mucor is there somewhere in the bone, palate, pterygoid, anywhere, any bone, there is no penetration of antifungal. If bone is involved, you have to remove it. If you miss the bony involvement without a good MRI, if you try to treat on the basis of CT scan, it's a joke. You cannot pick up all these sequences are not available on CT scan. A mucor cannot be properly treated, simply cannot, in bold letters, on the basis of CT scan. You must have MRI, otherwise it's a joke. So, you see, wherever the bone involvement is, no antifungal, liposomal amphotericin B, anything is going to work. You have to see how the bone is involved. Now, MRI can pick up bone involvement very nice. I can show you massive, funny bone involvement. We had to remove the entire skull bone sometimes. See this patient. We had to remove a big part of the skull bone. And many of the patients, number of patients we removed. See this. See this. Normally, a normal bone is never enhancing. See, whatever it is, enhancing on contrast means involvement of this area, and this is necrotic also. But I said when bone is involved, even enhancing, you have to remove it because there is hardly any penetration of antifungal. So we had to remove this entire frontal bone. See this, see this much. This entire frontal bone had to be removed thoroughly. Otherwise, you cannot give a justification to such patients. See this patient, you can never forget, is still surviving. That poor patient had massive involvement. See this entire frontal bone, right till even the almost going towards the vortex. This entire bone is destroyed by the external approach for such patient. Entire bone you have to remove. Otherwise, whatever antifungal you give is not going to work. So this is so important. Sometimes the fungus gives brain abscesses, and like this patient is still again surviving. But see, once there is an abscess, again, the antifungal do not work. See this, the brain abscess. See, the intranasal part was done by somebody. See, entire work is done. Good surgical work done. But you see what is happening? The brain abscess above. Not only here, there are multiple brain abscesses. See, brain abscess in the occipital region. And these are walled abscesses. Your antifungals are not going to penetrate. And amphotericin particularly has hardly any penetration, in the intracranial space. Very difficult, and such multiple brain abscesses. See this tentorial abscess. See this abscess above the posterior roof of the posterior sigmoid. These abscesses form when you find endoscopically your, the cribriform is necrose. That means you have to remove it, as otherwise this is going to lead to ascending infection above the layer. Many a times you have seen the involvement of the carotid artery. The carotid artery involvement is one of the most massive involvement, I would say. And there are certain patients where you find the carotid involved, massive brain, infarctions because of this disease. This is so bad a disease because once it is so aggressive, it gives multiple infarctions in the brain. I'll give you other examples of, see this massive disseminated mucormycosis. These are the patients now where you have your limits of the treatment and they don't, see this massive disseminated entire eyeball, entire almost 75% of the face is affected right from the soft tissues outside. This is mucor with multiple brain abscesses. This is see multiple disseminated walled brain abscesses. You can't help. You can't see the entire sphenoid with carotid 360-degree carotid. Now this is your limitation. You can't treat such patients. These are most difficult disseminated fungal disease. This patient we had treated and we had to remove a lot of things in the this patient. I'll give you one example where this was involving the TM joint and we had to remove the TM joint. The orbital abscesses, multiple abscesses in the orbit, massive disease in the infratemporal fossa, massive multiple abscesses in the temporalis muscle, going all the way into the massive multiple abscesses in all the muscles of mastication. All muscles, ipsilateral muscles having multiple abscesses, and you have no option but to remove everything because no antifungal is going to work. So there are such, patients where those poor patients, they have to suffer. There is no answer to such problems. See this patient had multiple infarctions in the brain. This is FLAIR imaging showing infarctions. Multiple infarctions into the brain because of the carotid occlusion. I'll give you another example. So you have to be, cautious about such patients where the disseminated disease can lead to problems. And it, because being the nature of the disease, this spreads very fast. Now, this patient, see this, had because of the vasculitis, the mucovasculitis, the carotid got blocked, completely blocked, had developed multiple infarctions. We have the angiogram also to show you. See this, first of all. That's the carotid artery on this side, and this carotid artery is a thrombus, not enhancing. This was a complete blockage of the carotid artery, which gave him problems. You see this. This is the carotid artery on this side. This is MR angiogram. That's the vertebral arteries on this side, both sides. This carotid artery. And this carotid artery had thrombus, completely, blocked. And ultimately, this patient developed a lot of infarctions in the brain and died. So there are variety of situations where this disease can present to different level. In the eye, there are patients where you can save the eye. There are patients where you need to, remove the eye. A lot of patients where we have given orbital clearance, having good vision or even the vision loss, yet we preserve the orbit. See, this patient had a lot of disease in the medial part of the orbit, but the vision was good, and we did the orbital clearance because the eyeball was not involved. If the eyeball is involved, you have to do exentration. See this. When the eyeball, anterior eyeball per se is involved, you have to exentrate. See this. So anteriorly, the eyeball and surrounding tissue is involved with multiple abscesses. Then there is no point in preserving the orbit in such situation. You have to clear it completely. If you have a limited disease in the eye, you can clear it. But if there is massive disease, you have to remove it to save the patient, because saving patient is a priority. See this patient has a limited abscesses in the eye. Young chap, 32-year-old, limited abscess in the eye, vision was good. So we did endoscopic from the same field, went inside the orbit and did clearance. These two necrotic areas, these were necrotic areas, and the antifungal worked, and we could preserve the eye. So exentration is different, clearance is different, and this patient.
Sir,
see the
in
funny-
case of, excuse me, sir.
Yes,
Sir, in
please.
cases of limited disease in the orbit, if we remove the part of muscle and this thing, diplopia will be there on movement of the eyeball will be hampered or not?
Yes, eyeball movement, yes, can hamper. But even if the vision is gone, if you are
Okay.
able to preserve the eye for the cosmetic purpose, it is good.
Cosmetic
It is not
purpose.
involving the eyeball. See
Yeah.
this patient, absolutely normal eyes on appearance, no paranasal sinus disease, hardly any paranasal sinus disease. This patient had presented with vision loss, mucormycosis, vision loss. And see what we observed. This is MR angiogram. This is carotid artery. Can you see the ophthalmic artery? Hello?
Yes, sir. Yes, sir.
Can you see the ophthalmic artery
It's
on
an
this side?
unseen. It's an unseen.
Yes. And see on this side, the ophthalmic artery is thrombosed, and patient presented with vision loss.
It's not an unseen. Yeah.
So sometimes you get no other finding, but your MRI can tell you what exactly is going on. So these are the patient. And another thing, sometimes patient present with disease, with little diminished vision or early vision loss. And how can you pick up? By means of, a good diffusion weighted imaging. See this patient. He presented with vision loss and presented to us in the evening, same day, and had an optic nerve infarct. Hardly any disease, very limited disease, yet presented with orbital involvement, preferential orbital involvement. See, this was the sinusitis and had infarct of the right optic nerve. In fact, very limited disease in the orbit, this one had infarct in the optic nerve. The infarct is best picked up by diffusion, and diffusion will tell you that this vision is not going to come back once infarct has involved the optic nerve. Optic nerve infarcts are irreversible. That's a part of the brain. Optic nerve is part of the brain. It's not like other nerves, part of the brain, prolongation of the brain tissue into the eye, and such, funny things you can pick up on MRI. So MRI in those situations is very, very useful. And we have cases ready. You want to see any more FESS, or do I come back there? Because a lot of people are leaving early, I came to know. So to show the post-operative management and the complication. Anything like the way you like.
So you can come here, sir.
Okay then.
Audience has to say. Want to see the case or?
One case you can show.
Okay, one side
One
I
normal
case.
FESS, yeah.
One case they want, sir.
just for the rehearsal what we had done yesterday. Okay,
So which case is ready, sir, now?
the cases are ready. All 4 cases are going on simultaneously. We had 12 cases today, so we are finishing them.
ये चारों टेबल पर ये संदीप लिया हुआ है अभी 2 पे अंदर पड़ा है 2 ये तो छोटा सा एक साइड किससे करेगा ये कुछ अजय ने इसमें लिख दिए किससे कौन सा कराना ठीक है देखो
सर आदमी क्या? Hello.
Hello. Yes, sir.
So quickly I'll show one side and then come over there. See this patient. Massive polyposis bilateral. Can you see?
Yes, sir. Hello. Yes, sir. We are seeing. This is pus, like.
Yeah, some discharge. See this big polyp occupying the entire nasal cavity. Same story on the opposite side, multiple polyps.
You haven't yet packed, sir, the nose, sir.
Pardon?
Nose is prepared with pack, or
No.
you want
No.
to do?
Now I'm
No.
preparing.
Yeah.
We never inject. It's a topical preparation only.
How many marrow cells are enough for a case?
So we cut 2 marrow cell and cut into different size 8 to 10 pieces.
8 to 10.
And the same marrow cell is used again and again during the surgery.
Okay.
Remove it, soak in saline, rinse it, squeeze it, dip in the same solution, saline adrenaline, and use it again during the entire surgery. At the end of the surgery, in the ethmoid cavity, you can pack few of these pieces soaked in dexamethasone. So the 2 marrow cell do all the purpose, they serve all entire purpose.
Sir, how much time you take for this preparation?
5 to 10 minutes. See, it is the application of the adrenaline on the mucosal surface which is required. It is not the pressure packing or anything which is required. If you pack it tightly, this is going to be counterproductive by means of giving venous congestion. There will be more venous bleeding. So just see, this marrow cell is compressible. You can open up, you leave somewhere, it expands and open up the narrow spaces. See, like this. It is so soft, atraumatic to the mucosa. See this, the polyps have been compressed by this because of the adrenaline. This is the vehicle to apply the adrenaline onto the mucosal surface. See this? This nose is much better now than what it was few minutes before.
Yes, sir.
See, all this mucosa should come in contact with the adrenaline. That's the aim. And it is so soft. See, not a slightest trauma you can observe anywhere.
What is the concentration of adrenaline here, sir?
In this
Xylocate.
elderly patient, this is 1:4. Young patient, we use, pure adrenaline even, because this is topical. This is not going to be, going into systemic circulation. It is pretty safe. Even the first application decongest the vessel to prevent absorption. And you can see this patient, our parameters. The pulse is 57. I told you to reduce cardiac output. BP is normal, normotensive. We never use hypotensive anesthesia. Can you see?
Yes, sir.
Yes, sir.
121 is systolic. The pulse is 57, which is the most important determinant. So don't go for hypotensive anesthesia. Go for reduced cardiac output. See, now I am.
Sir, 1:4 means like 20 cc, you use 5 cc of
Adrenaline.
adrenaline. Okay.
Yeah.
Can we use routinely like that?
Pardon?
Can we use routinely like that, sir?
Yeah. Young
1:4.
patient even use concentrated one, no problem.
1:2.
Even pure.
Direct adrenaline you can use.
young
That's what
patient,
he was
yeah.
telling. Direct adrenaline you can put it.
Yeah, young patient never a problem because you are not injecting.
Anyway, you are
Okay, sir.
monitoring on the monitor.
These were the polyps coming from the turbinate. See the turbinate?
Yes, sir.
See the middle meatus completely occupying the, and now the picture is better than, we can see some landmarks now. Luminal clearance is done. And
Sir,
we can see, this
can
is
you
your
tell us
uncinate
about-
process.
Sir,
This is your
turbinate
uncinate
management, can you please tell about turbinates?
Pardon?
Inferior turbinate management.
Inferior turbinate requires a lot of management in many of the patients. Majority of the patients like this, you can do just simple out fracture. It doesn't need further management. If there is bony hypertrophic, you can do a partial resection with minimal raw areas to give problem. If glandular hypertrophy boggy, then it has to be treated differently, and a posterior nasal neurectomy is helpful to denervate the turbinate on the postganglionic secretions. And sometimes your lateral nasal wall is projecting with the turbinate, then you have to do a lateral mobilization of the lateral nasal wall. You can make an incision over here, elevate the turbinate, remove the part of the lateral nasal wall, sparing the nasolacrimal duct, and the entire lateral wall you can mobilize laterally to open up the nasal space. So depending upon the situation, you can do that. So all these adjoint procedures are important whenever required. See this, I just out fractured the inferior turbinate and the space opened up. Can you see?
Yes, sir. But this comes back.
After some time, until then your inflammation will also subside.
Okay.
See the decongestion after every space. See how it opens up the space, how it gives you a perfect visualization. Now see, this is your mobile structure, uncinate. Can you see?
Yes, sir.
That's the uncinate. That is the uncinate. See, only mobile structure in the entire lateral nasal wall. This is hiatus seminaris. This is infundibulum. In the infundibulum, inferiolaterally, is the maxillary sinus ostium opens. So here, direct it little inferiorly. See this? Because if you direct superiorly, you are more close to the nasolacrimal duct. So come anteriorly until you come across the hard bone, and then you need to stop.
So this backbiting is of which make?
Yes. Here
Stores?
this, here this incipitate secretions, secondary infections, and now I remove this portion of, see this horizontal part of the turbinate which I have fractured. A horizontal part of the uncinate. With this. And now I can create a good middle meatal enterostomy. Obstruction. Still part of the horizontal uncinate is there. In this case, you know, the maxillary sinus doesn't have any massive disease. So I'm not converting to a mega enterostomy. This is all retained secretion. Mucosa looks little boggy, but not looking irreversibly damaged. See this? So allow the solution to go inside. It will revert back to normal. See the mucosa is just edematous. It is bound to come back to normal. Don't bother about it. Now the most important step, number one here, dealing with the upper part of the uncinate. See this? Go behind and fracture anteriorly. Away from the away from the critical structure behind.
Sir, if you have to do medial maxillectomy in this case, how would you like to proceed?
Medial maxillectomy. Medial maxillectomy, you have to remove this part of the mucosa, mucoperiosteum, come here to the level of the pyriform aperture, fracture the inferior turbinate separately and remove this bone. You can do that like we do for extended procedure, but here this is not required in this case. But yes, I will show after this for the maxillary sinus what all you can do. And like frontal we discussed just now. See this. This is your orbit. Can you see the lamina?
Yes, sir.
So the moment you remove the upper part of the uncinate, you should be able to reach and define your lateral wall of the sinonasal corridor, that is orbit. So that you don't cross that limit to give intraorbital complication. See my lateral limit I have defined. Okay?
Yes, sir.
In any given situation, I am not supposed to cross that. Define my axilla. See this? Completely define the axilla.
Yes.
This is your bulla ethmodalis.
Yes, sir.
This is bulla. This is axilla. This is your turbinate. See everything in picture? Now, time to change to 70 degree. In no time, you will see entering into the frontal sinus. Like you saw yesterday, we have already defined our three limits, three things, three landmarks for the frontal with 70 degree.
Your favorite instrument, sir.
Wire, Jawan. पकड़ना लग जाएगी वो। दे दो yes. See now with the 70.
Sir, can we see the outside picture also?
I didn't set up the external camera again. I showed you last time.
Yes, yeah.
Yes.
But in case of frontal, you do some different kind of a positioning.
Nothing. Same. See this. This is your lateral limit, that is lamina. Can you see?
Yes, sir.
You increase the neck flexion in this case, in frontal area.
No. This is your medial limit terminate. And see underneath, this is your beak. Can you see?
Yes, sir.
Can you see or not beak?
Yes, sir.
Yes, sir. We are seeing.
Thickest bone. This is thickest bone.
Yes, sir. Yes.
See, there is nothing secret. Go underneath the beak. You are not supposed to transgress your medial and lateral limit. You are staying anteriorly. You are
In flush with the beak.
centimeters away from the skull base. Don't worry.
In flush with the beak.
Follow the
Pardon?
beak.
In flush with the beak. No, sir.
Yeah,
We
flush with the beak. I didn't show you the CT scan of this patient. Sorry. We'll show you. Can you see the frontal?
Yes.
Yes, sir.
See the beak all the way. Same landmarks. Your turbinate. Stay between your medial and lateral limit and go along the beak wherever the beak ends. See wherever the beak ends is your frontal.
Yes.
Yes, sir.
There is nothing secret in it. What I am doing, you all can do, you all have to do. This is the most simplified way, but that much I can say.
Using 120 degrees, sir.
Yes. This is the safest way because what all you're, frightened with are in your view, landmarks. So turbinate, we are not going medial to the turbinate. Orbit, we are not going laterally beyond the lamina, which both landmarks are in our view. See this? And just flush the beak. See this beak?
Yes, sir.
You cannot debride this hard bone. And this is your frontal sinus. That's it.
Hello. Dr. Satish, one question, please.
Yes, please.
When we enter through the frontal beak into the frontal sinus, there are features whether we are seeing the cell or a frontal sinus.
Pardon?
Are we seeing the cell or are we seeing a frontal sinus? Any characteristics
This is
of a
frontal
cell?
sinus. That's why
Yeah.
whatever cellularity which
Yeah.
can complicate, you see on the CT scan before, but
Yeah.
this is not going to change this anatomy. See, if you start working from below,
Yeah,
in the frontal recess, you may come across so many cellularity.
exactly.
Here, along the beak, nothing is going to come.
Okay.
Simplest version, this is our own, version which we have brought out after having done at our center more than 10, 12,000, FESS surgeries. See this. Now, I told you, once you see the beak, my anterethmoidal artery is more than a centimeter behind. See this? I'm using the skull base blade to flush this, the posterior table of the frontal sinus. Want to flush this with the ethmoidal skull base. See this?
Yes, sir. Very nice.
That was frontal sinus anteriorly. This model skull base, and this is supraorbital. Can you see?
Yes, sir. Yeah.
And what is there in between is the party wall. See this. See the party wall between supraorbital and frontal. Sometimes the supraorbital cell is bigger than the frontal and one can get confused. See this. This is supraorbital cell. This is your frontal. This is party wall. I can break this party wall to widen the frontal in case required. Here the frontal is adequate, so generally you don't need 120. See this. See this? I'm breaking this party wall. See this? I've broken this. And now I can
So
widen.
in any differentiating features, whether we are seeing the supraorbital cell or the frontal cell.
That's why I
Differentiate-
said, see,
Yeah,
the
okay.
supraorbital cell is a posterior anatomy. It comes when the frontal sinus ends, when you come anterior to posterior. See this? I remove the party wall. See this?
Yes.
Now see, both cells becoming one. Can you see?
Yeah.
Yes, sir. Yes.
And we have adequate, see that. See this widening. In this widening, nowhere you will see the raw area. Can you see? Everywhere is the mucosa. See this?
Yes, sir.
Debrider is a mucosa preserving tool. It cuts sharp, it doesn't pull. That's why I use more and more debrider, because this is a mucosa preserving tool. See, with 70-degree, don't forget this view, what you are seeing, everything in view. That is frontal sinus, supraorbital, my beak is there. See, I went underneath the beak. Remember this space where I went. And this is always you will find like this. Beak is a constant landmark. Whatever can be the cellular variation, beak is never going to change. See this?
Yes, sir.
I hope it is very clear.
Very clear, sir.
Now I tell you another important thing. I always tell, whenever you see the supraorbital cell, immediately caudal to that is what? Anterethmoidal artery. Now see, it gives you a great landmark. See this. This is my supraorbital cell, and immediately caudal to that, what is that? Here should be the anterethmoidal artery. I will show you from both sides. See, here is my artery here. Let me go behind it. See, don't leave raw areas in the sinuses, in the drainage pathways. See, I am opening from behind to show you this. Can you see the vessel? Reverse.
Not clear, sir. अच्छा वो ऊपर वाला.
Just a minute. I will open up the space.
Sir, very close.
Can you see
Yeah.
the vessel?
Yes, sir.
Just to show you, I remove the
Sir, you are
covering.
using debrider on the anterethmoidal artery, sir.
You should have control. Nothing will happen. See the vessel? How I identified? See, it is immediately caudal to the
Supraorbital cell.
cell. So it's an important landmark. Once you see the supraorbital cell, the artery is going to be immediately caudal. That is the boundary of that space. Sometimes you have a bigger supraorbital cell, this artery is pushed behind. See this very clear now?
Yes, sir.
If I take a scissor and cut here in between, nothing will happen. I can coagulate, I can leave it, press with the marrow cell for a minute, it will stop. Like that. So don't bother. See, this is the vessel.
Okay.
See, the diameter is less than a millimeter. That's why you get fine sections done. So what I have done until now, I have done maxillary sinus work. That is the maxillary sinus work. I have done frontal sinus. I have done ethmoidal work, anterethmoidal roof work. See my turbinate, I didn't do anything to it. lying like a good baby along the septum. You are not supposed to disturb that. Best treatment to the turbinate is respect.
It doesn't respect you, sir.
Huh?
Turbinate.
Turbinate.
We have
See,
to
with our topical application, see the field. See the field. With normotensive anesthesia, not even hypotensive at all. Now I am clearing this orbital angle. This is very important sometimes. Otherwise, yesterday I had showed you one can easily leave the Heller cells. See this? Orbital angle, very clear. Anterethmoidal artery, supraorbital cell, and frontal sinus. All clear in one row. Good field, no infiltration. Now coming to zero back, and in next 5 minutes we'll be through. See this. Now see. Hello.
Yes, sir.
Yes, sir.
Going to the posterior group of cells. All major complications, happens to occur in the work which now I am going to start. The posterior ethmoid and sphenoid. All tigers are hidden in the sphenoid. And while doing posterior ethmoidectomy, if you are not aware that you accidentally entered into the sphenoid, you can damage them. Simply, this is our landmark maxillary line, roof of maxilla. Stay close to the turbinate, make an opening. Simple. This is the opening in the posterior ethmoid. See this? I am not doing posterior ethmoidectomy. I am going medial to look for a landmark. Can you see the superior turbinate?
Yes,
I
sir.
am trimming the lower half of the superior turbinate. See this?
Yes,
Yes.
sir.
Lower 1/3, it doesn't have any olfactory elements. See this?
Yes.
Medially is the septum. Now medially is the septum. See, this is septum. Now along the maxillary line, along the septum, if I go, I can see this. This is the turbinate. Now along the septum, should be along the septum. See this? Below the level of the maxillary line, this is your sphenoid sinus. See this? Just go flushing the septum. See this?
Okay.
If you don't flush it and go laterally, it can be a disaster.
Okay.
Always define your septum and go flush. Go below or at the level of the axillary line. This ostium is never along the floor. This is along the roof mostly, close to the roof. If you try to go not using this maxillary line, try to go up, you can give CSF leak. Okay?
Okay, sir.
Now, once I have seen this, now I will remove everything anterior to it. See this?
Yes, sir.
I can remove post-ethmoidal cells with much ease without any fear staying anterior to the sphenoid ostium. As long as you are anterior, there is no fear. No one can damage carotid artery, optic nerve. They can never come in any given abnormal situation anterior to the ostium. See the field. That's why the pre-operative, intraoperative preparation is important. See this? I have gone till the level of this. If I don't respect this landmark and keep on going laterally here to open the sphenoid, can be a disaster. And one can be easily carried away while opening the post-ethmoid. You never know when the sphenoid has come. Now the last part is widening this. See this? See the interior of the sphenoid? If it is a thick bone, you can take your punch to widen it. Yes. See this? Stay on the interior wall only and widen it. Punch is one of the safest way. This is widening of the
Sphenoid.
yes. Don't do anything inside unless you know what exactly you are doing. Suction.
Sir, these bony spicules, like you are removing with the debrider only.
Hmm.
Sometimes we feel like we need to use Blakesley, straight Blakesley to remove the bony spicules.
Yeah. If
Any
you have a
tip
good
to
suction,
remove?
you have a good suction backup, you can remove it.
With the
You
suction
know,
only.
the first and the foremost thing I want in the theater to be in order is the suction.
Which company, sir?
Okay.
Suction.
This is not a branded one. This is 1 HP.
Okay. It's normal regular suction only.
Not a regular one.
So you are removing roof.
Yes. So I am further widening by means of a through biting anteriorly, not behind, not posteriorly. I may damage the septal branch. And it looks adequate. The sphenoid had, unaeration. You can see the state of the mucosa, which need not to be removed. See this edematous? It will revert straight. It will revert when the steroid solution goes. See this picture? Orbit as a lateral wall, terminate. We didn't disturb at all.
Excellent, sir.
And the
Dr.
field is
Satish,
good.
can you show us how you pack now?
What?
How you pack the nasal cavity? How you pack it?
Pack
One
it.
by one.
Okay. Let me first irrigate. First, we wash it thoroughly.
Sir, any advantage you feel in using RL? Yesterday
Yes,
I was
RL is more physiological than NS.
any bleeding control. Bleeding is
No,
also
bleeding has nothing to do with that.
okay.
Bleeding has nothing to do with that.
Sir, you will mobilize the middle turbinate back to the position or you will leave it like that?
I didn't do anything to middle turbinate yet.
No, but
I
after
told you, see, marrow cell, same marrow cell, soaked in steroid, and you can keep in the cavity like this. That's it.
Okay.
See this?
this
Yes,
is mirror cell soaked in
And one
steroid.
more, if you are doing septoplasty or anything, you can keep one more, a long pack on either side in the nasal cavity.
Okay. And after 48 hours, you take it off.
Yes. So that's how one side is done. Other side I'm not showing. We are coming there. That's all.
Thank you, sir.
Thank you very much. Thank you.
Great.
हम कर दूं ये कर दूं टटवा आ रहा है इसके पीछे ये आ रहा है छोड़ दे अर्जुन 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 कर So, any questions? This was the CT scan of this patient. I forgot to show you.
Thank you, sir.
Welcome, sir. Coming there. You. Hello. Hello.
Hello, sir.
Yes, that is the CT scan of the same patient which just operated. Just forgot to tell you, show you before. So that's a classical one, agar. We saw the agar this one, and the maxillary regular one. Sphenoid, see the regular one with little mucosal edema and all that we have seen, but nothing significant. What was most of the thing is opacity because of the polyposis. So this was the surgical session, the first session of the day, and we can continue discussion on anybody having any doubts in the mind. What I believe after going back, you should be able to do all these procedures with the backup of understanding of chronic rhinosinusitis, what we discussed yesterday, what kind of a disease is, what kind of a patient is, any immunological, any microbiological, all those determinants, allergy, asthma, this, that, endotypes, everything has to be taken care of. And with that backup knowledge, if you treat, I believe nobody can stop you. And this is all these procedures, even the draft procedures, I believe you should be able to do it. There is no challenge. Only thing is the equipments and the zeal to do it without any fear. The draft is the area, the frontal sinus where we are operating is the safest zone. The only challenge is skull base, which is determined by the olfactory neuron. Don't go behind that and do anything what you want to do. Initially, you may give some damage to the skin or anything that may give buttonhole or anything. That's not a big complication. You can put a suture outside, nothing more than that. But that is a very, very safe zone, and you can practice in the cadaver also sometime to get used to that anatomy. And that the best part is the entire process is done by a 0-degree telescope. So you don't know sort of disorientation one can come across easily.
Excuse me, sir. Sir, can you elaborate a little bit more on cripple sinus, which you had put up? And also, there was this mention of facialization of frontal sinus.
Okay, facialization I had already mentioned. I can show you again. The cripple sinus was the same I was saying, like for the frontal I had shown you. Frontal I had shown you the various procedures, draft procedures, modification of the draft, then cranialization, facializations. All these are the procedures which are required for the, in the most difficult situation. Like the patient we operated draft 3 today. If she comes back, if the sinus doesn't maintain, drainage and still giving problem, we have to think beyond like cranialization, facialization, depending upon it. The facialization is when the anterior wall is eroded, remove whatever left anterior wall and remove all sinus mucosa, drill away until normal bone, block the frontal recess outflow and allow the front outside skin to fall upon the posterior wall. It may give a defect which you can reconstruct with a bone cement. That is successful provided you don't leave any mucosa buried underneath. So the first foremost thing is the mucosa removal. Complete radical removal of the mucosa is the priority before doing anything such. For maxillary sinus, there are sometimes challenging situations like hyperplastic maxillary. Be careful on CT scan. In this situation, what happened? The uncinate is very, very close to the orbit. See on the opposite normal side, the distance between this is uncinate, this is the, this part is the orbit. And I always tell this is the closest structure to the orbit, but in hypoplasty, even it becomes more closer. If you try to use, your sickle knife or anything to remove the uncinate, you're likely to enter into the orbit at the beginning of the procedure. So this is something not warranted. Some more thing about the maxillary sinus wanted to tell you. Okay, for maxillary sinus, sometimes you have a disease like yesterday you saw the trephination, the canine fossa approach. Though in maxillary sinus, what happens sometimes you have after the revisions, multiple revisions, you have a kind of a fibrotic sinus with multiple cavities, non-communicated to the, the drainage pathway. And you really need to remove all that, give a wide drainage. You need angle instrument, canine fossa enterostomy you can undertake, medial maxillectomy, prelacrimal approach. All these and ultimately leads to obliteration if the fibrosis happens. So there are certain cells which poses challenge. We pose challenge in the maxillary sinus. This is the Heller cell. Yesterday you saw the same Heller cell. I removed this partition to communicate with the maxillary sinus. Sometimes your multiple Heller cells, you see it narrows your infundibulum. Be careful. Otherwise, sometimes you are lost. And sometimes even if you have a bigger cell, you open the sinus, you remove the uncinate, you look like you open the sinus, which is actually a Heller cell, and you ignore the maxillary sinus. We have seen Heller cells even much beyond this, bigger than the, maxillary sinus itself. So there are variety of situations you have to be careful. Then this is canine fossa, and trust me, I had shown you yesterday, already shown you. This is 1 centimeter above your debrider, a 40 red directly without any cannula. It comes directly inside, and you can really somersault this everywhere, 360-degree with a 70-degree scope in view, and you can, you can reach out each and every nook and corner of the maxillary sinus in much more, comfortable way, and it is not associated with any complication or so. In a massive situation, you may have to do a medial maxillectomy. So, what I want to say overall, this CRS is a complex multifactorial disease. It's not a simple disease. You can compare it like, any syndrome, you can say, where multiple things, are contributing to the severity of the disease. And it's not a simple situation where one can think of, getting away all cases in a similar way. So it's a multifactorial disease, and the basis of a good overall outcome is understanding the pathophysiology, wherein we discussed a lot of things yesterday. That is the pillar of the success for the treatment of this disease. We need to know this disease in detail, and there are phenotypes and endotypes of this problem, which you must know. It's a medical disease. Don't forget, it's not all cases require surgery, and appropriate medical management is the core, except some exceptions which I mentioned yesterday, which are direct surgical candidate. And once it comes to surgery, an appropriate, surgery should be directed with keeping in mind preventing minimal to minimal level complications. That is the most important thing in the surgery, which we have discussed both days regarding the surgical part. And I'm coming there to discuss the post-operative, and the irrigations are the mainstay of the long-term outcome, because the topical steroid is the core treatment nowadays. Targeted therapy, of course, is the future. But still, in spite of understanding a lot of things, in spite of success in the surgery, in spite of advancement in the surgical technique, instrumentation, everything, we have still long way to go. Still, we have to, there are, tests needed to know the microbiome status. There is no clinical test to know the status of the individual patient's microbiome, immunity level, the biofilms. There are no clinical tests in the market to detect biofilms easily. No clinical test to know the genetic status and the genetic factors predisposing to the sinusitis. And of course, biologics is the future, where this is going to take over these clinical manifestation, and we can curb the disease in the earliest point, by targeting, at the molecular level. So this is about the sinusitis we need to understand. And still, as the science is evolving, we have to do more and more better, keeping the pace with the advancement in the medical science. And I hope once these core issues are solved, we'll be in much better position to treat this disease, in the future. Any questions?
Sir, if during surgery, if we see the lamina pepracia and we accidentally break the lamina pepracia and we see fat prolapsing, so what care should we take?
That's what I'm coming to. That's now last two sessions are aimed at the post-operative care and complications, managing complications. So, yes.
Just I wanted to know, you were talking about inferior turbinate. You have told there is you did denervate the inferior turbinate. Can you show any video or something here?
Yeah, that is simple. I could have shown you posterior nasal neurectomy. See, innervation means post-ganglionic supply to the glands in the inferior turbinate leading to hypertrophy. So basically, the nerve supply comes to the post-ganglionic, to the glands in the inferior turbinate, comes to the Facial nerve. Facial nerve giving a branch GSPN, which is basically a continuation of nervous intermedius. And GSPN continues to the foramen level, joins the deep petrosal nerve and become the median nerve. Median nerve coming to the pterygopalatine fossa, joining the pterygopalatine ganglion, and from there the postganglionic fiber, the posterior nasal nerve, come in the posterior part of the nasal cavity through the pterygoid, perpendicular plate of the pterygoid plate and the sphenopalatine foramen, and those nerve filaments enter the turbinate to supply the postganglionic, to the gland fiber, supply to the gland. So if we target those postganglionic fibers, we can reduce this glandular stimulation and hypertrophy of the turbinate. That is what I mean to say. What you can do, use a cobblator in the region where those nerve fibers come to the inferior turbinate. So in the posterior part of the nasal cavity, those fibers come to the mucosa. The mucosa between middle and inferior turbinate can be cobblated to automatically cobblate those nerve fibers, making them non-functional. And it really helps in, dealing with the, soft tissue hypertrophy of the turbinate. Bony hypertrophy, you can do a partial bony resection.
Okay.
That is what I mean to say.
But where we have to do exactly? Just behind the maglisinus ostium, or it's just
behind the maxillary sinus. Behind the maxillary sinus, where the perpendicular plate of the palatine bone is, the sphenopalatine foramen is.
Okay, okay. Is there any role of Vidian neurectomy or something?
Oh, Vidian neurectomy. See, where we are, what fibers we are targeting? Postganglionic fibers, which are carried through the Vidian nerve and delivered in the pterygopalatine ganglion, and from there, the fibers which are destined for the nasal and palatine glands, we are targeting them. Now, if we target the Vidian nerve before coming to the ganglion, that Vidian nerve contains the postganglionic fibers to the lacrimal gland also.
Okay.
We can unnecessarily give a dry eye, which can happen in certain percentage of the patient. Why to?
Yes,
We have to do a selective denervation by means of targeting the posterior nasal nerve.
Is there any role? Earlier we used to say, like in sympathetic, vasomotor rhinitis cases, you do Vidian neurectomy or something.
Yes, so
it's gone now.
When this science was not developed to the level of understanding of the posterior nasal nerve, Vidian neurectomy used to be answered, and the commonest complication would be the dry eye, which has stopped us from doing, operate kare main samjha. The commonest complication has been that, and that's why it has not been, very, very popular surgery. It has been disregarded after that because of this complication. The posterior nasal neurectomy, yes, you can accomplish without any such severe complication.
How common you encounter vasomotor rhinitis, sir, in your practice?
I can't say. Most of the time it goes undiagnosed, the symptomatology is so overlapping.
Yeah.
So I can't say in terms of percentage, but yes.
Is there any direct test or something? We can
not really.
Because it's a very overlapping kind of a thing.
Yes. But by and large, the treatment is same. Yes, in that situation, if you do a posterior nasal neurectomy, it is more effective. That much I can say.
Thank you.
Excuse me, sir.
No.
Sir, while doing sinus surgeries, is there any point to note whether it is of tubercular etiology, like later on sometime there is persistent discharge and then we get gen expert done?
In paranasal sinuses, we have encountered tubercular sinusitis. Chronic granulomatous diseases have many, differential diagnoses in the nasal cavity, like chronic aspergillosis present with granuloma. So many other chronic pathologies which can present with granuloma, rhinoscleroma, Sjogren's, so many things can involve the paranasal sinuses, but that presentation is always unusual. See, sinusitis has classical features, classical clinical finding, classical mucosal finding, which is not there in any chronic disease, and that can make you suspicious, can take a biopsy, and tuberculosis is very well medically treatable. So we have seen tuberculosis, not very common.
those patients used to complain of like mucormycosis like symptoms. So
Yeah,
we
so there
send
are
it.
unusual problems. I told you, sinusitis has a different symptomatology, different appearance of the mucosa, everything, predictable. But something unusual, you need to take biopsy and confirm and direct the treatment. That's why I mentioned in the MRI also, if the patient presents with some abnormal symptoms, which is not correlated with the sinus disease, not correlated with your endoscopic finding and endoscopic picture, must get MRI done. MRI by virtue of various, ability to give various sequences, you can pick up such unusual diagnosis much easily than CT scan, which just gives opacity, cannot differentiate between soft tissue.
Sir, a slight deviation from the topic. Regarding DCR, I would like to ask, do you intubate?
Yes, we do all under general anesthesia, all nasal surgery under
No,
general
no,
anesthesia.
not endotracheal, like lacrimal intubation.
Not really, except in revision situations, sometimes you have a very, very fibrotic wall. Because we marsupialize, not only, we just don't open the sac and come out. We marsupialize the entire nasolacrimal system. We go above the level of the common canaliculus to the dome of the sac, which is almost 5 to 8 millimeters above the level of the dome of the sac is above the level of the common canaliculus. So right from there till nasolacrimal duct below, we marsupialize the entire nasolacrimal system on both sides like an open book. You don't leave any raw area, and it doesn't direct you to use the all those cannular stents or all those things.
Reserved for revisions only.
Very, very rarely.
So in a patient whose one eye had a revision and we intubated, the other eye we are doing for the first time. Should we intubate prophylactically?
Not really. See, even in the revisions, if you do a proper marsupialization, you don't feel like using the stents, and self is a problem. So unless you can't help it with become so fibrotic, you don't need to do anything.
When very small sac, sir, but like
Yes, if
lacrimal
you do a
sac.
good marsupialization, you can follow it. You can, do a regular syringing for some period of time to flush out anything blocking, rather than prophylactically intubating it. Prophylactic intubation, I don't see any advantage.
So status of steroid-eluting stents.
Yes, I have kept in one of the slide in my presentation post-op care. So steroid-eluting stents were introduced and approved by the FDA also. The Propel is the stent which has been approved by the FDA. It, on a periodical basis, it keeps on eluting mometazone. So it is a biodegradable stent. It's like a spring. It serves dual purpose of keeping the ethmoidal cavity open and keeps on eluting the mometazone from time to time. So it's good. It elutes the steroid, keeps the cavity open, and then degrades itself. You don't need to remove it, after a period of time. But the cost is a limiting factor, and still you need, saline irrigation and all that to improve the mucociliary clearance. So because of the cost and not having any significant added advantage than the douching, this have not gained popularity. A Propel costs around nowadays probably $900 or something for a month, which is not a viable thing for a CRS patient who requires, majority of them require a lifetime follow-up and irrigation and all that. In a country like ours, it is not a viable thing, what I believe.
One more question I had regarding anterior DNS. We get to struggle in that. So how to efficiently manage anterior DNS especially?
Same endoscopically, you can refix to the opposite side and to the intranasal spine. So it doesn't fall back and you can go ahead.
Okay, sir. Thank you.
So I think this is the time you can go for a lunch, and I'm coming over there, and in 15-20 minutes we can start our final session. I think the lunch is served there. Anybody from Sipla? Has lunch been served?
So one more point, just out of this contest, can you tell the younger doctors, postgraduates, or the one who has just finished and started practice regarding the consumer protection? If you can give some guidelines, that will be very useful to them, because of late I have seen, at least our party is over, but these youngsters are very worried about this legal proceedings. So can you really highlight just 2 minutes of your
I mentioned couple of times during presentation that there are a lot of issues which can be medical legal, and the thing which protects you is the good radiology and good documentation and patient shared decision making with the patient, because nothing is hard and fast in management. You have to choose the best way, and that has to be communicated well with the patient, given all options. Surgery is the best answer still if you want to continue with the medical treatment. These are the adverse effects. These are the pros and cons. That's it. Don't try to impose, because this disease, you know, what I mentioned, less than 10% of the patients are coming to ENT. Rest are being still managed by the GPs and family physicians and pulmonologists, you know, with the medical management, though may not be, you know, evidence-based, but, you know, they get symptomatic relief and it is something going on. So you have to be following the evidence-based medicine, shared decision-making, documentation, good understanding of the disease and the radiology. That can prevent you, to getting into all that litigations. And surgery, obviously, the radiology is a big role in preventing complication, pre-operative preparation. All those are important. The single most important factor in preventing intraoperative complication is the visualization that is best given out by the pre-operative and intraoperative preparation. So don't rush for that. Operating every patient fast, prepare adequate. Sometimes I've got to know the patient, tell that we have to operate fast, the patient may run away, it becomes symptom free, when you give steroids and antibiotics. You have to tell them, make them understand, we'll operate once you become symptom free, you feel like you're normal, so that we can execute the best surgery. It's all counseling and shared decision making.
well taken points.
So let's meet after the lunch, and you can meantime have your lunch, and then we'll start our next session. Thank you once again.
Thank you, sir. Thank you very much.
Yeah, good afternoon, delegates. The lunch is just outside of as yesterday we was having. We have forwarded one link.
बिल्कुल जोर से ले वाह